So we are live in 3, 2, 1. Please start, sir. We are live.
Hello, good evening and namaskar. It's a pleasure to welcome you all for this exciting webinar, which is now divided into the 4 parts. We have exciting discussions on the 4th and 5th of November. Now, this is very much dedicated to the clinical management of common cancers, a newer perspective. Today is a day which is dedicated to the head and neck cancer and ovarian cancer, and it's a pleasure to welcome and invite the convener, Dr. Tarachand Gupta, sir, he's a consultant medical oncologist at the prestigious Bhagwan Mahavir Cancer Hospital and Research Institute at Jaipur. So once again, a very good evening from all of us. Good evening, Dr. Tarachand, sir. Over to you for your welcome introduction and taking the proceedings further, please.
Thank you, Tarunji. Respected teachers, friends, and colleagues, it's our great pleasure to warmly welcome you to be a part of the virtual conference Clinical Management of Common Cancers Newly Perspectives, which is being organized since the 4th November in a consecutive 2 weeks. 2 days already gone, 4th and 5th, and today is the 3rd day, 11th November, and it will be continued till tomorrow. The goal of this conference is to improve the knowledge and competence of cancer treatment participants to apply practice-changing clinical data and expert recommendation to optimize clinical outcomes for patients receiving therapy in cancer. Experts are likely to help physicians and practitioners put the role of multiple therapies in a clinical context and discuss how they can effectively contribute to patient care. Treatment regimens will be discussed on head and neck cancer and ovarian today. And we have discussed earlier GI cancer and GU cancer and breast cancer. So head and neck cancer, we are very badly said capital of world in the head and neck cancer. But from last 3 years, we are rocking on an international platform because of the Dr. Vijay Patil, Dr. Kumar Prash, and etc. At all for the newly therapies and new treatment options, which have changed the treatment paradigm and the results unexpectedly. So this conference is already organized under the aegis of Prime Oncology Society, Raipur, and supported by Cancer Research and Statistics Foundation. So for the first talk, I invite now Dr. Arun Chandrasekaran for chemotherapy options for the concurrent chemotherapy in cisplatin eligible patient and non-oral cavity cancer patients. So Dr. Arun Chandrasekaran, over to you.
Yeah, thank you, Dr. Tarachand. Thank you for this opportunity. And the topic which I will be presenting is the use of concurrent chemotherapy in cisplatin eligible patients with non-oral cavity head and neck cancers. So this is something very site specific, which we'll be discussing today. I'll just put this on full screen. Yeah. So basically, we'll be covering 2 aspects: the usage of cisplatin in the definitive chemoradiation setting and the usage of cisplatin in the adjuvant setting. So first, we look at cisplatin in the definitive chemoradiation setting. So here we have many trials which initially looked at the benefit of cisplatin in a definitive role. One of the NEGM trials, which was done way back in 2008, was the trial by Forestier, which proved that in patients with laryngeal cancer, radiation with concurrent administration of cisplatin was superior to induction therapy followed by radiation therapy, or to radiation therapy alone for the purpose of laryngeal preservation and for loco-regional control. So this is what established cisplatin in a definitive role, and what the further trials have built on this. And one of the newer trials which was done in AIIMS, which was presented in this ASCO 2022, was the trial from AIIMS, which looked at the comparison of a weekly cisplatin dose to a 3-weekly dose in locally advanced head and neck cancer. Now, the reason we're discussing this is because this trial enrolled multiple patients in the definitive setting, which you'll be seeing later. This was known as the CONCERT trial. The abstract has been presented in ASCO with the final paper pending. This included patients with locally advanced head and neck cancer and randomized around 270 patients into one arm receiving cisplatin at 40 milligram per meter square dose for 7 doses, or cisplatin as a bolus 100 milligram per meter square every 3 weeks for 3 doses. So the main endpoint was 2-year loco-regional rate, and secondary endpoints was OS, PFS, toxicity, and compliance. So cisplatin was being used in a weekly basis prior to this trial in based on retrospective analysis, because the 3-weekly dose was considered too toxic or had multiple side effects. But there was no proper randomized data in the definitive setting. So this trial tried to answer that, and the sites of disease was majority in the non-oral cavity areas, with the oropharynx being the most common and 60% of the patients, and oral cavity was just 11% of the population. And in this population of oropharyngeal cancer, 13% had HPV positivity. So the results of the trial after a median follow-up of 26 months showed that weekly cisplatin had non-inferior loco-regional control, non-inferior PFS, and a non-inferior overall survival. The toxicity was lesser with weekly cisplatin, and grade 3 mucositis, kidney toxicity, and vomiting all were much higher with the bolus, that is every 3 weeks dose of cisplatin. So this trial established that you could use a weekly dose of cisplatin in the definitive chemoradiotherapy setting. Then the other questions to be answered was, is cisplatin better to other agents, or are other agents comparable to cisplatin as well? Could you use other radiosensitizers instead of cisplatin in cisplatin eligible population? So this was the RTOG 1016 trial, which looked at a comparison of cetuximab versus cisplatin as a radiosensitizer in HPV positive oropharyngeal cancer. So it's known as the de-escalate trial. The reason this trial was done is because people in the West, they believe that HPV positive oral cancer has a better prognosis. So using a toxic therapy like cisplatin could be, replaced with something less toxic like cetuximab, and patients could have better outcomes and lesser long-term toxicity, especially in this HPV positive population, as these people do better and have better responses to treatment. However, the final results showed that cetuximab was inferior to cisplatin, and cisplatin is still the superior drug. Now, can cisplatin be combined with other agents? The answer is yes, and we have the trial by Dr. Vijay Patil et al. And Dr. Kumar Prabhash and the head and neck team, where they studied the use of an EGFR inhibitor, nimotuzumab, in combination with cisplatin, along with radiation in patients with locally advanced head and neck cancer. Here also, the majority of patients were non-oral cavity cancers, as we'll see. So patients with locally advanced cancers of the oropharynx, larynx, or hypopharynx with adequate organ function, they were randomized 1:1, 268 patients in each arm. One arm received nimotuzumab, cisplatin, and radiation. The other one received just cisplatin and radiation. Both groups received around 7 cycles in total. And the primary endpoint was progression-free survival, with secondary endpoints of DFS, loco-regional control, and overall survival. So if you see the patient population here, the oropharynx was the majority of patients enrolled in the trial. Oral cavity was less than 1%. So this tells you this answers the question of the use of cisplatin plus another agent in the definitive chemoradiotherapy setting. This was the PFS curves, which shows separation, and it's 61% versus 50% progression-free survival benefit with a hazard ratio of 0.69. However, overall survival, the data was a little immature that time, and the updated analysis also, there was no difference in overall survival, only a PFS benefit, which was the primary endpoint. So this trial was positive for its primary endpoint. However, there were certain issues with the trial, which was brought up by various editors later on. One was the dose of cisplatin used, which was 30 milligram per meter square. So the question was that maybe the control arm was undertreated with a dose of 30 milligram per meter square and should have received a dose of 40 milligram per meter square. But subgroup analysis and later analysis show that the adequate dose of cisplatin, which is 200 milligram per meter square, was received in a majority of the patients here. Also, there was no OS benefit. So could you, take this information and apply it, to improve overall survival? These were the issues. So a subgroup analysis of the same trial looked at which is the best population that you can use nimotuzumab along with cisplatin, and that was the trial which looked at the HPV negative population with oropharyngeal cancer. And in this, when you looked at this subgroup with HPV negative oropharyngeal cancer, which is the most common or type of oropharyngeal cancer in India, the loco-regional control, the overall survival, and the progression-free survival all were significantly improved. So the population of HPV negative oropharyngeal CA is the population that if you're going to use nimotuzumab plus cisplatin, this is the population where you're going to have the maximum benefit. Other drugs have been tried like avelumab, pembrolizumab, cetuximab in concurrent with cisplatin, and all of them did not show any major benefit or were not proven to have benefit yet in phase 3 trials, or phase 3 trials are still ongoing. The other few drugs combined with cisplatin have been panitumab, erlotinib. Also, again, this did not show any benefit. There is a new class of drug which is known as DEBO-114, which is an inhibitor of apoptosis proteins, and this was combined with cisplatin, and this showed some efficacy in a phase 2 trial. Although this data has to be tested in a phase 3 trial as well. So that is definitive chemoradiotherapy. Now moving to the adjuvant setting or the post-operative use of cisplatin with radiation. So you had the seminal trials in 2004, which showed that post-operative use of concurrent chemoradiation was beneficial. The outcomes of both these trials showed that concurrent chemoradiation improved loco-regional control, with showing additive or synergistic benefit of chemotherapy to radiation. And the chemotherapy used in these trials was cisplatin as a bolus on day 1, day 22, and day 43. So 3-weekly cisplatin became the standard of care in the post-operative setting. Now, again, the question of tolerance came into being, and many institutes were using a weekly dose of cisplatin so as to combat the side effects. And in this, there was no randomized phase 3 trial in the post-operative setting, and this is where the TMH group looked at the comparison of a weekly versus a 3-weekly regimen. And this was published in the JCO. And here, as you can see, in the trial, the majority of patients taken were patients with oral cavity cancers in almost 87% of the population. And the other cancers were quite lesser. So this was mostly in the post-operative setting. And cisplatin was given as adjuvant in 93% of the patients over there because it was used in oral cavity as a post-operative. And the dose of cisplatin used as a weekly regimen was 30 milligram per meter square, which was the institute standard at that time. And if you see the results of the the loco-regional control with the 3-weekly cisplatin was slightly better than the weekly cisplatin. So actually the bolus 3-weekly dose was superior to the weekly dose. And since this was a non-inferiority trial, this non-inferiority was not proven. And based on this trial, 3-weekly cisplatin was still better than the weekly cisplatin. However, the issues with this trial was that the dose of cisplatin was on the lower side, which was 30 milligram per meter square. And it was postulated that this trial mainly took in patients with oral cavity cancer, so should be applied into patients who were HPV negative and with majority being oral cavity primaries. The main issue was with the dosage, which was 30 milligram per meter square. So even after this randomized trial, the question was, what if the dose was higher? Would it have been non-inferior? So this was the trial that answered that question, published in April 2022, which is the Japanese JCOG 1008 trial. This was also another very similar non-inferiority trial, which looked at weekly versus 3-weekly cisplatin in the post-operative setting. This was the trial design, which was very similar to the previous trial, with one arm receiving the weekly, but this time at 40 milligram per meter square for 7 cycles versus 100 milligram per meter square for 3 cycles. Here also the population was oral cavity was seen in 46% of the population, and the other larynx, oropharynx, and hypopharynx formed almost 54% of the total population. So 54% of this trial had received non-oral cavity cisplatin plus radiation in the adjuvant setting, in the post-operative setting. So here is the comparison of the curves, and this shows that weekly cisplatin is slightly better, and this is the overall survival curves, which you can see here. And the trial proved that it was non-inferior. Weekly cisplatin was non-inferior to 3-weekly cisplatin in post-operative high-risk locally advanced squamous cell lung cancer. And also the side effects were much better with, as you can see, weekly cisplatin had less dysphagia, less nausea, less renal impairment, and less hearing impairment. So the question was, why was this trial positive while the trial in India and TMH was negative? Again, the big question is probably it's because of the 40 milligram per meter square, which was giving a higher cumulative dose when you compare it with the Indian trial. Also, the dose intensity of cisplatin with 40 milligram per meter square is higher than the 3-weekly, which gives you a dose intensity of 300 milligram per meter square per week. And Indian trial had only 30 milligram per meter square per week. So higher cumulative dose and higher dose intensity probably could have resulted in better outcomes. But the problems with this Japanese trial is also there. One is it's a small sample size. So for the small sample size, they used a wide margin of error. So you could have 27% worse outcomes than of weekly cisplatin than 3-weekly, and still the trial would have been non-inferior. So they took a wide margin, which many of the other admins, as in other faculty, were not too happy with. Also, there was not proper stratification or matching in the random assignment, so that could have been a non-random distribution of risk factors. And higher risk patients were seen in the 3-weekly arm, N3, T4, and hypopharynx tumors. So this is definitely good information from the Japanese trial, but there are some flaws with it as well. But based on this, the recommendation would be a usage of a weekly cisplatin dose. This we can skip. This is a meta-analysis which was done previously, which showed that weekly is comparable to 3-weekly, but it's not in taken in the newer trials. The future shows the NRG HN009 trial, which is looking at radical CTRT only population, which is again comparing 3-weekly to weekly. So this has taken only that specific subpopulation. So that is what is happening in the future. And to finally conclude, the choice of drug in adjuvant and definitive setting is cisplatin. The ideal dose is either 40 or 100 milligram per meter square, but 40 milligram per meter square is better tolerated. And you can combine cisplatin with nimotuzumab, especially in HPV negative oropharyngeal cancer, to get better outcomes. I think that's the last slide. Thank you for your patient listening.
Thank you, Arun. Nice presentation. And what is your choice, Arun, in a cisplatin eligible patient for CTRT in a patient of larynx, at least, not the base of tongue or the oropharynx?
Okay, in larynx, still I would use cisplatin. I'm not using the bolus dose. I'm sticking to 40 milligram per meter square as of now. Because most of our patients, which I see in our population, most of them are above the age of 65, 70. Head and neck cancer is quite rare in Kerala, honestly, compared to North. So 40 milligram per meter square is what I personally use. Okay. I think you had better experiences with the bolus dose. With I
am using 3-weekly and weekly schedule equally. So we have a good data around 70-80 patients in last 1 year of 3-weekly cisplatin, and around 100 patients same times at 40 milligram per meter square. But we have not analyzed till now the data. So what about your choice in of Biomev in larynx and CTRT?
Larynx, yeah. So larynx, I would still, I would, if the patient is fit, cisplatin eligible, I'm not using it. As I said, the oropharynx with HPV negative would be the population. But again, in that, the dose which I give would be on the slightly lesser side, 30 milligram per meter square, combination with nimotuzumab, because I think a higher dose might increase the amount of mucositis and could lead to some treatment delay with radiation, which we definitely do not want. So I have used it in the oropharyngeal setting, but not in the larynx. Larynx still, just cisplatin without nimotuzumab, I think is what I, routinely practice.
Okay, thank you, Arun. So for the next talk, I invite our dear and respected Sir Dr. Vijay Patil. He is an associate professor in Tata Memorial Hospital, Mumbai, and medical oncology. He will be speaking on chemotherapy options for concurrent chemoradiation in cisplatin ineligible patients. Sir, please. Vijay sir.
Just a second, I'm sharing my slides. Is the slide visible?
Yes, sir, it's visible.
Yeah, okay. So what I'll do is I'll present the data of Dhanush study. This is probably the only randomized study which has been done in cisplatin ineligible patients. And as we go along, we'll discuss what are the other options which we can use. Now, what we know, and Aruna has put forward that when we give chemoradiation, cisplatin remains the standard of care. And majority of the world still uses 100 milligram per meter square. In Indian practice, we do use weekly cisplatin also. Now, cisplatin unsuitable patients is not uncommon. And when you look at the data, around 25 to 30% of your patients will be cisplatin ineligible. Now, what are the options which we have in this patient? And this is a single slide which is giving you all the details. We look at one of the options which is very commonly used called cetuximab. Now, what we must understand that the data for cetuximab gets extrapolated from the Bonner study, which was actually done in the definitive setting. And we don't actually have data that whether cisplatin unsuitable patients could tolerate it or not. In fact, there was a study done which was specifically for cisplatin unsuitable patients. It was done in France. It's reported in Head and Neck Journal in 2019, in which they had to stop the study after the first 8 patients recruited because of severe toxicities of dermatitis and dysphagia, which happened in this patient with cetuximab and RT. Now, apart from that, but cetuximab is being used in spite of this limited data in many of the centers. And if you look at all the immunotherapy trials which are happening in cisplatin in unsuitable patients, you could see that cetuximab is the standard of care arm which has been used. Now, why is this difference that one French study had to be stopped versus other trials are still recruiting and they have not reported excess of toxicities? This is because of the criteria of cisplatin unsuitabilities. Most of the pharma studies, MNC studies of immunotherapy which have been doing, they're taking the criteria of unsuitability as a creatinine clearance of less than 60 ml per minute or sensory neural hearing loss. These are the only 2 criteria which they are taking. Now, the issue is when we look at the criteria for cisplatin unsuitability, there are other criteria like an elderly patients, multiple comorbidities if they are there, patient is poorly nourished or has malnourishments, or patient's albumin is low, or he has lost a significant weight loss. It's been seen that when these other criteria are there, along with, and if these criteria get included as cisplatin unsuitability, then these patients tend to have a lot more toxicities than those 2 criteria which most of the studies are taking, that is only hearing loss or creatinine clearance of less than 60 ml per minute. So cetuximab is one place in India because of the high cost. It's not that commonly used, but in West it is one of the agent which is been considered for in cisplatin unsuitable patients. But the issue is that there is very limited data to say that to say that if you do a study of RT versus cetuximab RT, that it would have a survival advantage. To that extent, there was also a SEER database analysis which came in 2022, in which it was clearly shown that cetuximab RT, those patients received had inferior survivals than RT alone. obviously the whole group who received RT alone and cetuximab RT also had inferior survivals than patient who received cisplatin. But that also can be because of many of the cetuximab patients and RT patients were cisplatin ineligible. So that puts a doubt in the mind that how extrapolated data of cetuximab from cisplatin fit patients would work in cisplatin unfit patients. The next regimen is a carboplatin 5-2 regimen. This is practice in GORTEC. So basically in the French group again. And this regimen is exclusively studied in the French GORTEC studies, especially in the definitive setting. We don't have data in the adjuvant setting, and we don't have data in the cisplatin unsuitable setting also. We have given carboplatin 5-FU in 17 patients in Tata. And in this, the 5-FU is given infusional. And now when you give infusional 5-FUs in DCF or CF alone, you get mucositis. Now you can imagine if the patient is taking radiation along with infusional 5-FU, there tend to be high amount of toxicities. We also need to understand that there is a higher incidence of DYPD mutation in India, and which is up to the tune of 1 in 4 patients. So in such situation, again, if you give carboplatin 5-FU, it may land up in problems. Now, carboplatin is one of the agents which is very commonly go to the agent in cisplatin unsuitable patients. Frankly, if you look at the McKenzie analysis, RT versus carboplatin RT, there is no survival benefit, DFS benefit, or local control with addition of carboplatin. There are in fact 2 direct randomized studies in the adjuvant setting which have shown that there is no benefit of adding carboplatin. But this remains one of the very popular agent and seems to be a practice across the country, even though there is very limited evidence. In fact, there is negative evidence that it does not benefit the patients. The other agent is 5-FU hydroxyurea. And this is a part of a regimen called Vokes regimen, which has been popularized by the University of Chicago. And this is mainly used in re-radiation settings. And the patients already has exhausted the option of cisplatin. Now this, if you want to use 5-FU hydroxyurea, you need to give patients split course regimens. Limited centers in North America use it. We have used it in 6 to 7 patients, and this also leads to quite amount of toxicities. Paclitaxel carboplatin is another option which can be given, but has only a limited single arm phase 2 data, so no actually efficacy data. So when you look at all these options, we actually saw that there was no option which was actually tested in cisplatin unsuitable, and hence the study was done. Very simple design, patients who were cisplatin unsuitable, and this was in accordance with the EMANS criteria. One arm had radiation, another arm docetaxel and radiation, and 2-year disease-free survival was the endpoint. These were the criteria of cisplatin ineligibility which were taken in this study. Any one of these criteria could label the patient as cisplatin ineligible, but you could see that when I show you the paper has got accepted and in JCO and would be in full text in a few months now, that multiple patients, 60-70 actually had more than one criteria. This is the sample size calculation, and you can see that we had 176 patients in the radiation arm and 180 patients in the docetaxel radiation arm, and nearly all patients were there for intention to analysis. One patient refused to take docetaxel along with RT, and so in the per protocol analysis of the dossier, there's one patient less. There are a few interesting things which you need to see here. If you looked at the data which was shown by Arun, in which you would have clearly seen that the median age of the patient in all those trials was actually 40 years or 50 years. This was a study specifically done in cisplatin ineligible patients. And you could see that the median age is around 60 years, which was nearly 50% of patients were above 60. And if you look at 70 as a cutoff for elderly, then nearly 15% of the patients, 15 to 20% of the patients were actually above the age of 70. Nearly 35% of the patients were actually above the age of 65. So quite a huge number of patients who were elderly. Let's look at the ECOG performance status. And there is another surprise here. If you looked at the data which Arun showed for consort study or even for weekly, 3 weekly or for you would see that the number of patients of ECOG performance status 2 would be in single digits. You could see here that there are nearly 40 to 50% of the patients who were ECOG performance status 2. This is a population. If you look at McKenzie analysis, it would say that it doesn't benefit from chemotherapy. And so this population was enrolled here. So what I'm trying to tell you is, you would see that docetaxel led to a lot amount of side effects, but also understand that these were unfit patients. They were largely elderly patients. They were largely PS2 patients. And this is the kind of patients which we are not seeing in studies in which MNCs are doing, in which you are actually looking at patients in which creatinine clearance is lower, only hearing loss is there. Most of them had a higher stages of tumor. And if you look at the hemoglobin levels, you could see that many of them are malnourished also. Nearly 50% of the patients had lesser hemoglobin levels. And this is the criteria which I was talking about. If you total the numbers, you could see that they cross the number of patients, because many patients had more than 1 EA. And you could see that weight loss, poor PS, uncontrolled diabetes, uncontrolled hypertension, there were quite a few patients in this study. Most of these patients were treated with two-dimensional techniques. And in spite of these being frail, you could see that in both arms, the compliance was good, with most of the 90% of greater the patient getting 90% of the doses. Radiation interruptions were seen in 10% of the patient. If you look at docetaxel, and it's clear there is a study of RTUG 0234 when docetaxel was given. And in that docetaxel now, even if you look at the DECIDES paradigm study in which docetaxel was given, 5 cycles of docetaxel actually are considered adequate. You could see the median number of cycles received were 6, and greater than 85% of the patient actually received 5 cycles of docetaxel. And adverse event was one of the commonest causes for not giving the 5th cycle. Of course, you add any systemic therapy to radiotherapy, it nearly doubles your complications. So there was a higher incidence of mucositis and odynophagia and dysphagia, and to some extent of some amount of dermatitis also. But you should not be getting disturbed by this. Understand that these are frail patients and you are going to get toxicities in these patients. But did this toxicity lead to improvement in survival? Yeah, it led to an absolute advantage of 12% in disease-free survival, which comes out to a hazard ratio of 0.67 and is maintained. You could see that the separation keeps maintaining up to 3 years, which was around the time this study was running, and it is benefits across all subgroup of patients. If you look at the overall survival, it led to a similar amount of nearly 10% benefit in overall survival also, with a hazard ratio of around 0.7. And again, the benefit was there across all subsites. Now, understand that we said that there was a higher amount of mucositis and side effects in docetaxel. The question is whether that impacted the quality of life. And this is a graph in which we actually have done quality of life analysis for individual patients. Normally, whenever we get quality of life, we get those graphs. We do it for a cohort. So we don't understand what happens at the individual levels. And in this study, we had planned it, thankfully, to see what happens at individual levels. So every patient quality of life was actually compared with its quality of life at baseline. And this is the quality of life parameter at 6 months, which I'm showing it to you. So what it shows you is, if you look at the first curve of change in trial outcome index, it shows you that patients who were in docetaxel and radiation arm, a less amount of decrement in quality of life was seen in this patient, 35% versus 25.4%. If you look at it for the fact G score, again you will see, and the fact head and neck, there was a lesser amount of quality of life derangement which was seen in these patients. What does this mean? This means that those acute complications which you had, see, those acute complications, CTIT goes for 3 months. After 3 months, the patient comes up first follow-up. So this is actually what you are seeing at the first follow-up of the patient. Post completion of CTIT, they nearly get settled by that time. And the quality of life decrement is actually less because disease starts increasing. And why was that kind of analysis important? Because this is what you see when you look as a group. When you look as a group, you see that the scores are nearly similar between the trials. But when you look at the individual patients, you would see that a higher amount of patients in RTR had decrement in quality of life. Now, there are some limitations in this study, which is common, that most of the patients use two-dimensional radiotherapy. But the primary endpoint was OS and DFS, and there is hardly any data apart from nasopharynx that IMRT or 3D CRT for that matter improves outcomes. It improves xerostomia, but not outcomes. We included both adjuvant and definitive patients. See, we wanted to have a pragmatic study, and there was limited incidence at that time when we saw cisplatin unsuitable patients. So we wanted to include both so that the study recruitment would get over. And of course, it was a single center study, but its strengths are very also there. It's the first randomized study in platinum unsuitable group. We've used docetaxel, which is widely available drug, had improvement in DFS and OS. And in fact, this was one of the comments which we got from the reviewers, that though the side effects are actually manageable and they are not in the age, so we actually have scope for escalating the dose of docetaxel or adding an agent to docetaxel further in the CA. So to conclude, it's like that addition of docetaxel to radiation improves outcomes in cisplatin, and this represents a new standard of care in these patients in which there was hardly any study done before this. I would like to thank the whole team here and the whole head and neck DMG for that. If there are any questions, I'll take.
Thank you, Vijay sir. Sir, what is your choice in cisplatin ineligible patients for the concurrent chemotherapy?
So it is docetaxel nowadays. So it's very clear. We अगर fit है तो 100, नहीं है तो docetaxel.
Okay, docetaxel.
If I find that patient is very frail,
Okay.
very frail means एकदम ही PS2 bar 3 है, elderly 80 years है, or patient has some this what you say lung changes या COPD के जैसे बहुत ज्यादा हुए तो docetaxel देके pneumonitis ना हो जाए. In that situation, I would opt for nimotuzumab in the patients.
Because of the OS benefit and the quality of life benefit.
Docetaxel I'll opt every time if the patient I fit is for docetaxel, because there is a DFS benefit, OS benefit, and quality of life benefit, and even the cost is less. Nimotuzumab, if the patient is unfit for docetaxel, and actually based on one of the papers from Dr. Govind Babu, in which there were 100 patients, 25 in 4 arms. One was having RT cisplatin, nimotuzumab, RT nimotuzumab, only RT arm, in which it was shown that in eligible patients, RT versus RT nimotuzumab, there was a survival advantage in patients who took RT plus nimotuzumab.
Okay.
It's published in Oral Oncology in 2014, I guess.
Thank you, sir, for a wonderful presentation. And now I invite for the next stop, first line treatment for metastatic head and neck cancer, IO plus CT versus cetuximab combination. Dr. Sangeeta Parthivan, consultant medical oncologist, ESIC Hospital, Bangalore. Sangeeta, over to you.
Thank you, Dr. Tara. Thank you to the organizers and Dr. Tara for this invitation. I think after detailed discussion by Vijay Patil sir, it would be difficult for us to concentrate on the next session. But moving on to the session, today's topic given to me was to talk about the first line treatment options for metastatic non-nasopharyngeal head and neck cancers. So whether the choose of therapy, whether it is an immune checkpoint inhibitors with the combination of chemotherapy or versus the cetuximab and the chemotherapy combinations. Seconds. Okay. So we all know that we see around 30 to 40% of the patients coming to us with the relapsed or metastatic head and neck cancers, and they'll all have different needs and abilities. Say it could be whether they're not able to tolerate the chemotherapy, or whether they have a heavy burden of disease which needs a rapid response, or some of them needs a treatment which prolongs the survival. So in each of these patients, it's very necessary to personalize our care for such patients and at different treatment goals in each of these patients. So some of them, it would be only a symptom control and prevent the new symptoms as an emergency measure. And there could be, it is also along with it, the tumor shrinkage, which could be the tumor response, and also increasing the survival and quality of life. So there are some factors that we really choose before trying to choose a therapy in our patients. So one is to see what is the burden of the disease, and also looking for the comorbidities, performance status, and also the prior therapy. And a more important as of now, the biomarker, the CPS score. So we are going to basically discuss the clinical trials. So one is, we all know there's the EXTREME trial, which was published in NEJM, which was a change of therapy in all these patients, which was the platinum-based chemotherapy plus cetuximab in head and neck cancer, published in 2008 at the NEJM journal by Warmoker et al. So here the trial basically included around 442 patients, where they stratified them into the chemotherapy arm Along with the other arm was the chemotherapy, including the cetuximab arm, and cetuximab was continued until the progressive disease. The chemotherapy used in both the arms was the 5-FU, the daily continuous infusion dose along with carboplatin, and the cetuximab was a weekly dose, the initial dose of 400 followed by 250 until the disease progression. The endpoints we were looking for, the primary endpoint was overall survival, and secondary endpoint was PFS, response rate, disease control rate, quality of life, and safety. So this was the 5-year follow-up. We all know, we are very, very well aware how it became a standard of choice in all of our metastatic head and neck cancer patients. So we could see here, so the median overall survival, so it was around 10.1 versus the 7.4 months in the chemotherapy alone arm, which was statistically significant. So thereby it became the first standard of care for all these patients. So we, though this study is about usage of about, platinum and taxane, I think in Indian setting, we already had started using because of the cumbersome difficulty administration, this 5-FU cisplatin. So this trial where TP Extreme trial is nothing but same as the Extreme, but the chemotherapy was instead of 5-FU cisplatin, the chemotherapy that was used was docetaxel with cisplatin along with cetuximab. And as well, cetuximab when continued in the maintenance setting, it also tried to look the role of 2 weekly cetuximab, which could ease the administration in our patients. So, and as expected, the trial did show a similar overall survival and overall response rate to the Extreme regimen, and indeed with the lower rates of progressive disease. So thereby, we have started using the taxane-based regimen in our routine setting. So these are the differences. We know that, we could now use even biweekly cetuximab. Apart from that, as already explained about the cumbersome nature of 5-FU infusion, we could be avoided by the single-day taxanes. And also the adverse events were much lesser. And the number of cycles exposure required was less. And the other contraindications in particular was the extreme is if cardiotoxic, it would be difficult to use the 5-FU, and TP Extreme for the doxy GI toxicities. So then we know after this, we have had a long break, which has definitely shown a survival benefit. So then a role of immunotherapy came in. So this is the study that was published in Lancet in 2019. So where they studied the role of pembro alone or with chemotherapy versus the cetuximab with chemotherapy in recurrent head and neck metastatic squamous cell carcinoma patients, excluding the nasopharyngeal cancers. So the inclusion criteria were as below. So the squamous cell carcinomas of all the sites, excluding the nasopharynx, if they were relapsed or metastatic setting with a performance score of 0 or 1. And there was also assessment of PD-L1 assessment in them, and also P16 status was assessed. So the stratification factors were PD-L1 expression of TPS more than or equal to 50 and less than 50. And later an amendment was made to this, and they used the CPS scoring. So they're stratified into 3 different arms. You could see either the pembro mono arm, pembrolizumab with the chemotherapy arm, then the chemotherapy used was 5-FU with cisplatin or carboplatin, and the extreme arm where we use the 5-FU cisplatin and cetuximab arm. And the number of cycles were minimum of 35 cycles, and they were continued in patients who had required. So the endpoint looking was with the survival. So here we could see pembro monotherapy has not shown a superior overall survival in the intent to treat population, but yes, in the CPS score more than 1 and CPS score more than 20, there was a definite survival benefit we could see. So the median of 12.3 months versus 10.3 months in the extreme arm. And in CPS more than 20, there was a more benefit with 14.8 months versus 10.7 months. This is with the pembro monotherapy. And pembro plus chemotherapy showed definite benefit, superior. It was a superiority trial, so it definitely showed a superior benefit, overall survival benefit in all the 3 arms, be it in the intent to treat population or the CPS more than 1 or CPS more than 20. And the maximum say in CPS more than 20, the median overall survival was 14.7 months versus the 11 months. So the trial definitely was a positive trial and did meet its primary end. But we all know that yes, it didn't have a PFS benefit. And the other important thing that was noted was the progression rate was higher in both pembro and the pembro chemotherapy arm rather than compared to the extreme arm. And there was also a response rate. We could see the overall response rate was higher in the extreme arm than the Pembro or the Pembro arm. So the trial again, this was 5-year results of the Keynote 48, which was presented at the ESMO 2022. So where they tried to see it did concord the similar results as in the primary results. So the Pembro plus chemo had shown superior overall survival in all the population. I think it was almost, they were followed up around more than 60 months, and then definitely there was a definite benefit in all the three settings, all the three populations, be it the intent to treat or the CPS more than 1 or the CPS more than 20. So apart from this, as we saw in the previous, there was no PFS benefit, and then definitely the graph started separating after the 6 to 9 months, and then there was no PFS benefit. It did concord with the preliminary results. The other important thing that we could see is, yes, here there was the overall response rate. If you see with the Pembro and the chemotherapy arm, probably after attaining response 2, there was a change in response. So the overall response rate, which was initially lesser when compared to extreme, it was similar at 5-year end results, but then the disease progression rate was higher in the Pembro, in the immunotherapy arm rather than the extreme arm trial. And when coming to safety, this graph definitely proves that, yes, they did not show any alarming signs. It was safer to use immunotherapy and immunotherapy along with chemotherapy, though the immunotherapy along with chemotherapy when compared to extreme had a slight grade 3 to grade 5 adverse events at a higher rate. So now, having discussed these both trials, which really are game changers, where you have a survival benefit with both of them, and then definitely with the Pembro plus chemotherapy showing definite survival benefit in all the population, we know that probably I would, in a given setting, keeping apart the logistic issues, so probably we would choose the Pembro plus immunotherapy, Pembro plus chemotherapy to all our patients, but yes, with the exceptions. And apart from that, we want to know what would be the correct sequence of in these patients. Do we have really a randomized study? No. We do have some data. This is from Taiwan by Chen Yang et al., which was just a retrospective observational study where they found similar benefit whether cetuximab was given first followed by immunotherapy or immunotherapy followed by the cetuximab group. It was almost similar, though it's just the observational study. And yes. So having known all this, so do we want to do we have an overall survival data with these? You're giving the first immuno combination and then going ahead? No, we do have some post-hoc analysis data of PFS2. That means it did show, the Keynote 48 did show that after using the immunotherapy combination, patients do respond to the other lines of therapy, especially taxanes, were had much survival benefit when used in the second line setting than the non-taxanes. So there is we do not have OS data as yet with the Pembro first followed by the extreme. So having said all this, so we know the data, but there are some groups, in a given setting, if you give me, probably I would like to counsel the patient for the, Pembro plus chemotherapy arm, chemotherapy combination for the choice of therapy. But yes, there are some groups in which probably decision is still difficult and still not clear. So one, we know that where the CPS score is less than 1. So there were probably less than 15% of the patients, and they were neither pre-specified. So this makes us a difficult decision whether, and this, whatever the 4-year data did not show, Pembro or Pembro plus chemo did not show a superior benefit in compared to the extreme. So what do we need to use there is a question mark. And again, there are some patients probably where CPS score less than 1, where they may respond to this immunotherapy. So do we have to use any other biomarkers like tumor mutational burden is another question mark. So probably some of the studies could answer them in future. So again, coming to CPS 1 to 19, we know that these are not pre-specified group, but yes, as Keynote 48 sub-analysis post-hoc data did show that, Pembro plus chemo was slightly, and overall survival benefit was slightly higher than the single agent chemo. So maybe we could use Pembro plus chemo in them. And what about patients with no PD-L1 assessment? That is again a question mark. And we know that patients with only loco-regional recurrence. So there was also an other analysis made at Keynote 048 was that, slightly, though at the preliminary results did show benefit in all the group, but there is a study there, the sub-analysis did favor cetuximab in some of the population with the loco-regional recurrence. So do we have to use cetuximab combination or do we have to use immunotherapy in them is another question. And we do not know about patients who are not included, like say who have progressed within 6 months of radical therapy, or patients with have symptomatic CNS mets. So what needs to be the choice of therapy in them is another question. And yes, we know that there are some data to say that around 29 to 30% are hyperprogressors. In hyperprogressors, by choosing a cetuximab, so, not choosing an immunotherapy, are we trying to, reduce the survival? Overall survival is another question. So apart from that, yes, whenever there's a high tumor burden, bleeding tumors or obstruction, which are not included in the study, you want a rapid response and you would like to choose the cetuximab-based combination therapy. So these are probably, I'm also waiting for the panel discussion to see on, what would be my other colleagues and seniors' choice in this population. So in conclusion, I would like to say, yes, treatment decisions have to be, personalized in all of the head and neck cancer patients. It is very important to choose a combination therapy which has the maximum response in first line. And that would be the time when the patient is still fit for the same. Yes, with the available data, we definitely have that pembrolizumab combination with chemo combination as an overall survival benefit across all the patients in the study. And cetuximab with different combinations have also shown a consistent response rate and overall survival. And we have already taken into our daily practice the TPX where you use the taxane-based regimen. And we may probably need to also understand in future about the sequencing of these therapy, considering both improve the survival. And the present NCCN guidelines, if you see, they have already mentioned both cetuximab with cisplatin 5 the extreme trial regimen and the pembro and the platinum 5 both to be a category 1 recommendation in these patients. And when the score is more, and pembrolizumab for patients with more than CPS more than 1, and it's category 1 recommendation if it is CPS more than 20. So with this, I would like to conclude my session and thank you, and waiting for the panel discussion too. Thank you, Dr. Tarachand and the team for this.
Thank you, Sangeeta, for a wonderful presentation and making that very clear-cut choice. We have to use the IO plus chemo versus we have to use the cetuximab. Now for the Merck sponsor, I invite Dr. Rajat Shah, consultant medical oncologist, Max Super Specialty Hospital, Delhi, for the Merck sponsored session, individualizing patient journey in recurrent metastatic head and neck cancers. So Dr. Rajat Shah, please, over to you.
Thank you very much, Dr. Tarachand, and I thank the organizers for giving the opportunity and Merck for providing the slide sets for this. I literally apologize for probably some disturbance in the. I'm actually willing for able to see my slides?
Yes, sir.
Yes. So the topic which I am going to present is individualizing patient journey recurrent metastatic because I'm noticing that we both have almost the similar sets where we would be discussing the main key trials in the recurrent metastatic setting of head and neck cancers. So yes, we have gone a long way from the year 2000 and we single agent chemotherapy, and then we went on to chemotherapy combinations. Then in 2008, the extreme regimen came with one of the first trials which showed an improvement in the overall survival. Then we went on to the advent of the immune checkpoint inhibitors in the second line setting. And subsequently in 2019, the TP Extreme trial came, and simultaneously along with that came the immune checkpoint inhibitors plus chemotherapy combinations. Various combinations were there. And now, yes, as Dr. Sangeeta has told, we are now entering an era of which is the better sequence in which to handle our patients. So what we see here in part of the world is a different biology of head and neck cancer. Our head and neck cancers are not very much HPV driven, as unlike in the Western population where it is HPV driven. And again, we have a higher stage of presentation and a lower age of presentation. So definitely the biology, the molecular biology is different. And in India, about 87% are reported as tobacco users. And among oral cancers, tobacco users definitely have a poor survival as compared to non-tobacco users. And we all know that these patients are presenting at a comparatively higher stage, and they require a more aggressive treatment. And another issue is the logistic means the financial constraint of most of our patients in this head cancer subgroup. So the main highlight of this talk would be the various clinical trials which have catapulted cetuximab and chemotherapy into the first line setting. And in the next part of the talk, we'll just be talking about the immunotherapy first line setting also. So this trial has been discussed by my previous speaker. This is the very famous extreme trial data by Vermaken et al. And this slide has also been discussed previously. The chemotherapy versus chemotherapy plus cetuximab, and cetuximab was given until progression. So definitely this showed an improvement in the overall survival of approximately 2.5 months. And this we will just wait and ponder on this thing, that in this overall survival, the curves are separating quite early. So just remember this, and when we focus on the immunotherapy trials, we'll see what happens to the Kaplan-Meier curves. So yes, this trial definitely showed a survival advantage, and in the oral cavity and in almost all the subgroups, the cetuximab plus chemotherapy arm was better. So definitely there was an improvement in the quality of life also in patients receiving cetuximab plus chemotherapy for recurrent or metastatic head and neck cancer patients. There was there an impact of tumor HPV status on the outcome in patients with recurrent or metastatic head and neck cancer? The author's conclusion in this trial was that the survival benefits of chemotherapy plus cetuximab was independent of the tumor HPV or the tumor P16, which is generally taken as the surrogate marker of HPV. So irrespective of the HPV, we can definitely choose cetuximab plus chemotherapy combination. So comorbidities are quite common in the head and neck cancer patients, and in our patient population, about 57% patients have some comorbidities or the other. It may be cardiac, respiratory, or hypertension, and this is where the taxane plus chemotherapy comes into the taxanes as a choice of chemotherapy comes into picture. And the 5FU is not very much in vogue nowadays because of the cumbersome method of administration, the need of a central line placement, and more admission costs. And this is the TP Extreme data, which again has been discussed in detail by our previous speaker. I would just like to go over the few salient points once again. The most important point here is the ease of administration. So this requires only means basically just this requires daycare admission. That is what is required. And it is a once in 3 weekly treatment, and we are overall the cost of therapy is definitely lesser. So definitely there was an improvement in the median overall survival with the TP extreme arm at 14.5 months. And this was not basically a means it was kind of non-inferior to the extreme trial data. So this again, I would just like to revise once again that the patients had a better chemotherapy exposure. More number of patients were able to complete the treatment arm, and the maintenance in this was a bi-weekly cetuximab at 500 milligram per meter square versus the weekly cetuximab in the extreme arm. So overall, lesser patients means lesser hospital visits is the main key in this trial. We have used docetaxel, cisplatin, and cetuximab, and more commonly, I would say that we are using the paclitaxel, platinum, and cetuximab combination also. So we are also using the weekly paclitaxel carboplatin or the weekly paclitaxel cisplatin plus chemotherapy, and a lot of two Indian trials have also showed that such patients have a good overall response rates and with a good overall survival. So we have got robust data from the Asian population and more commonly the Indian population, which has shown that the taxane, especially the paclitaxel, weekly paclitaxel plus chemotherapy, means plus cetuximab, is definitely a good option to use in our Indian population with a slightly lesser performance score. Now, just focusing on the immunotherapy trials, we definitely have the KEYNOTE-048, which is the landmark trial for pembrolizumab. These were the trial arms. And definitely in the overall survival arm, definitely in the CPS score greater than 1 or CPS score greater than 20, pembrolizumab has been found to be superior. Definitely there is slight controversy of pembrolizumab monotherapy in the CPS greater than 1, but in CPS greater than 20, definitely it is there. What I would like to just point out is in these Kaplan-Meier curves, what we can see, it is not an early separation, but the separation of the curves happen quite later on in the duration of the treatment. So, however, what I would like to point out is in the head and neck cancer patient who has a very high disease of burden, and the disease burden of the disease is more in the critical areas, maybe causing dysphagia, maybe causing voice change, maybe causing some stridor. So in such patients of means critical disease burden, I would say, are we suited to give the pembrolizumab or pembrolizumab plus chemotherapy arm? That is a question to be answered, because as we know with any immunotherapy chemotherapy combination, the responses are there, but the responses are very slow, and some of the about 18 to 20% patients or 25% patients definitely go into a long-term overall survival, but we are still not able to identify those 15 to 20% of patients who are going into longer overall survival. So, and we definitely have the risks of means basically hyperprogression. I'll discuss in the next 1 or 2 slides. This is the pembrolizumab plus chemotherapy arm, again in the CPS score greater than 1 and the CPS score greater than 20, and in the intent to treat population, there was an overall survival advantage of each of the things. And Dr. Sangeeta has already pointed out, however, that the progression-free survival is not very much improved with the this combination. So that means we are not getting a rapid response. That is a very important thing to note. So as long as the treatment-related adverse events is concerned, definitely the pembro monotherapy arm has definitely a favorable toxicity profile. And when we combine pembro plus chemo versus the extreme arm, generally the side effect profile is mainly similar. That is mostly attributed to the chemotherapy arm. Now, this slide has also been discussed, and I would again like to revise that double the rates of progressive disease with pembrolizumab plus chemotherapy is seen vis-a-vis the cetuximab plus chemotherapy arm. So that is a very important thing for us to counsel, and it is a very difficult thing to explain to our patients when a patient is taking such an expensive treatment, that these patients may land up in progressive disease quite early on in the treatment phase. So what is the reason for this progressive disease? The reason for this progressive disease, the one of the most important reason is basically the hyper progressive disease. So hyper progressive disease is one phenomenon which is seen very commonly with the head and neck cancer patients, and this leads to a rapid deterioration of the health and probably a mortality in our patients also. Now, what are the reasons for this, molecular reasons for this hyperprogression? One of the reasons which has been found out is the MDM2 mutations or amplifications, which is there in our head and neck cancer patients. And here we can see in the MDM2 mutated patients, the overall survival in the immune checkpoint inhibitor arm is lesser as compared to the non-amplified patients. So that is a very detrimental factor which we generally do not check in our clinics. We generally give immunotherapy based on the CPS score, on the PDL1 status, but we fail to check these MDM2 scores, and we also fail to check other markers of immune means immune non-tolerance, like STK11 is also there, which leads to a cold environment whereby the immunotherapy may not function so well. So again, there is always a controversy of the CPS score 1 to 19 population, and ultimately about 57% of the patients are falling under less than 20% CPS score, and these patients are definitely an iffy with the pembrolizumab chemotherapy arm. So this is the basically the subset analysis of the CPS score 1 to 19 of pembrolizumab alone or with chemotherapy in this combination. And there was definitely in the CPS score less than 1, there was not much of a benefit. In the CPS score 1 to 19, basically there was benefit with pembrolizumab plus chemotherapy, but the benefit with pembrolizumab monotherapy is not so much. And we definitely need more robust biomarkers apart from PDL1, like Dr. Sangeeta told, TMB status or other NGS markers we need to actually more define our patients for immunotherapy. So coming to the sequencing, what is the optimum sequencing after the TP Extreme trial, after the Keynote 048 trial? So the logical thing is, do we use cetuximab upfront followed by immunotherapy, or do we use immunotherapy upfront followed by cetuximab? I would like to reiterate that the usage of immunotherapy upfront followed by cetuximab, there is a lack of data. Not many trials have used cetuximab in the second line setting, and that leads to a paucity of data and leads to a little insecurity of us using cetuximab in the second line. Whereas we definitely have data of using immunotherapy in the second line setting after failure of the cetuximab. So that gives us more confidence to use cetuximab in the first line setting where the patients have more symptomatic disease, more high burden of disease, and we need a rapid response. We can use cetuximab upfront. This can be followed up by immunotherapy. How and where do we get this confidence from? Is this trial in this arm, in the extreme trial data, when we used immunotherapy after the means after cetuximab, there was not much improvement in the overall survival. Whereas in the more often used TP Extreme arm, if we are using immunotherapy after the TP Extreme trial, after progression on TP Extreme, we are getting a very good overall survival advantage of 21.9 months if we are using this sequence of TP Extreme followed by immunotherapy. So this is overall means this is what is giving us the confidence of using immunotherapy in the second line arm as compared to the vice versa. Another important aspect which we would like to share, we had Dr. Vijay Patil just now speaking about another path-breaking docetaxel concurrent chemotherapy, but their group has also put the oral OMCT, the oral metronomic chemotherapy, into the world map. And this is the harsh reality of the Indian subcontinent, whereby a lot of our patients are neither able to afford cetuximab or are able to afford the immunotherapy. And this low-cost metronomic chemotherapy definitely is a way to go forward in such patients. So this was a trial conducted by their group, the Tata Memorial Group, whereby they showed that there was an improvement in the oral with the usage of oral metronomic chemotherapy vis-a-vis the single agent intravenous cisplatin. The comparative arm was a single agent intravenous cisplatin. However, we do use generally the weekly paclitaxel carbo or weekly paclitaxel cisplatin. That would be slightly it will decrease the gap between these two Kaplan-Meier curves. But definitely oral metronomic chemotherapy is a very good suggestion for the lower socioeconomic strata population. Definitely the quality of life indices are also quite maintained, and this OMCT is here to stay. Another important study, which again has been pioneered by Dr. Patil, which was recently presented, is the addition of low-dose nivolumab and oral metronomic chemotherapy. So this is a very interesting study of low-dose nivolumab of 20 milligrams, which has been used every 3 weekly, in addition to the oral metronomic chemotherapy. And the results was that the addition of low-dose nivolumab led to improved overall survival and is an alternative standard of care to those who cannot access full-dose nivolumab. So using full-dose pembrolizumab and nivolumab in a resource-crunched setting of India is very, very difficult. So here we have basically a good regimen whereby we can use a suboptimal as per the Western standards, but probably enough for us to gain a good benefit for our patients. So in a nutshell, what are the choices of treatment? Yes, we have the cetuximab plus platinum taxane combination, which is, I would say, is the frontline treatment for high burden disease, for critical burden disease patients who have comparatively a better performance status. IO-based combinations are also there. Definitely, they have proved their mettle in the CPS score greater than 20. And we also have metronomic chemotherapy. So I was just mentioning the confidence of using nivolumab or any immuno-oncology drugs after cetuximab failure. So these are the few trials. One is the Checkmate 141 trial, phase 3 trial of nivolumab after progression. And this trial has showed an improvement in the median overall survival over the standard therapy. So definitely we can use nivolumab after the failure of cetuximab. And there was an improvement in the overall survival. And this is the Keynote 040 trial, which has used pembrolizumab after failure of the standard chemotherapy regimen. And they have compared it with investigators' choice of therapy. And overall, all this data is giving us means a kind of a confidence that we can use immunotherapy in the second line setting also. So to conclude, definitely each patient of recurrent metastatic head and neck cancer is unique, and genetically and etiologically, Indian patients are different than the Western population. And that is why we definitely welcome these path-breaking trials which come up from the Tata Center, which utilize this means this difference in our Indian population. There are factors like tumor burden, the pace of disease, the biomarker status, which are very important in deciding the treatment for the head and neck cancer patients. Results of the CPS score greater than 1 is influenced by the CPS score greater than 20 subgroup in the Keynote 048. So this is the fine print which we need to differentiate and probably choose our patients wisely. With the ASCO 2020 TP Extreme trial and our own experiences of using Pacli Carbo and cetuximab, the cetuximab based regimen in the first line, followed by immunotherapy in the second line, is a very valid treatment option with overall survival reaching approximately 22 months. Thank you very much. And open to any discussions.
Thank you, Dr. Rajat Saha, for a comprehensive presentation and taking every point of the head and neck cancer management. It's a useful guide for the managing the head and neck cancer in clinics also. Thank you very much. Now, next is our panel discussion. For that, I invite Dr. Amish Vora, who is a co-founder, director, Hope Oncology Clinic, Delhi, He will be discussing the management of recurrent and metastatic head and neck cancer in next 30 minutes. His esteemed panelists are Dr. Gunjesh Singh, Consultant Medical Oncology, Bhagwan Mahavir Medical Super Specialty Hospital, Ranchi. Dr. Tanmay Kumar Mandal, Consultant Medical and Hemato-Oncologist, Amri Hospital, Dhakuria, Kolkata. Dr. Sushant Mittal, he is Associate Director, Medical Oncology, Max Super Specialty Hospital, New Delhi. Dr. Avinav Jawar, Consultant Medical Oncologist, Aurangabad. Dr. Monica Bopanna, Consultant Medical Oncologist, Krishna Institute of Medical Sciences, Secunderabad, Hyderabad. Dr. Satwik Khadar, Consultant Medical Oncology, SRJ CVCC Hospital, Indore. So, Dr. Amish Vora, sir, over to you.
So, hi, Dr. Tarachand, thank you. I see there are 6 panelists, is that correct?
Yes, but Dr. Preeti and Dr. Suresh is not joined, and Dr. Gunjesh is having a network issue.
Dr. Gunjesh is having a network issue.
Yeah, I try Gunjesh, what is the problem? I said, check.
Understood. So, Geetika, can I have my slide? Have you received my slides?
So, not received yet.
No, I sent it on the email. I will share my screen. My only problem is that, it gets hanged.
Can you please share your PPT on my WhatsApp?
Sorry?
Can you please share your PPT on my WhatsApp?
How can I share your PPT on the WhatsApp? इतना सब मुझे आता तो क्या चाहिए था, Geetika? Let me see, it has reached my this thing cancerconference@gmail में ना पहुंच गया है. It shows sent. आप refresh करोगे तो आ जाएगा. 6:43 PM को चला गया है.
Sir, I'll take one.
Just 1 minute. Let me see if I can. Is my slide seen?
Yes, sir.
Yes, sir. Visible, sir. Audible and
Visible.
visible.
So,
all good, please.
So sometimes na it because of my MacBook issue it gets hanged. So Geetika, तब तक आप देख लो, अगर आपका हो जाता है तो then you take over. ठीक है? So let me start with Sushant. Sushant, you are there. Dr. Sushant Mittal, is he there?
No, sir.
Okay. Dr. Tanmoy?
Yes, I am there.
Okay, so let's start with Dr. Tanmoy. Dr. Tanmoy, this is something which normally we never discuss in medical oncology conference. Before we go on to medical oncology aspect, which are the patients where you feel that you would send the patients for surgery in recurrent head and neck cancer?
See, for a recurrent head and neck cancer, if the disease is still localized, and if it's a good disease-free interval, means it's around more than 1 year or 2 years, if it's a good DFI, and if the patient's general condition or the performance status is fine, if it's a localized disease, and the surgeon says that it's a resectable one, I generally send them for a re-surgery again.
Okay, so low volume you say. So suppose assuming somebody who has relapsed after say 9 months, and 9 months of previous surgery versus 9 months of previous CTRT, which patient would you select for surgery?
So post CTRT, if the disease, if the patient means post surgery, post CTRT, if that is the scenario and the patient relapses again, then a repeat CTRT is not possible in that patient, that scenario. So for that, I will always want this patient to go ahead with the surgery again.
With surgery. So Dr. Tanmoy has brought out a very important point. I think we should not forget that there are certain patients who would be amenable for surgery or the local treatment. Before we go on, all Keynote 048 and Extreme Trial and TPX, there are some patients who would do very well. And since we are talking of recurrent head and neck cancer, so that is what I felt we should not forget. Dr. Sathwik, are you there?
Yes, sir, I'm there.
So Dr. Sathwik, I'm really amazed at NCCN guidelines. And Dr. Sathwik, yeah, I can see you now. If you see preferred regimen में सिर्फ IO and IO ही है. Are you a little surprised that in a country like India, especially, 2020, there was the Extreme Trial was category 1. Now, other recommended regimen में combination treatment mein, they are still kept Extreme Trial as category 1, but preferred regimen is only this. And even if there is CPS less than 1, still they say that you can give pembrolizumab with chemotherapy. Are you surprised, or do you think that this is not correct?
So I'm not surprised with NCCN guidelines because over the years, what I have and every one of us have experienced that the guidelines are just guidelines. So that is what our teachers used to say, that they are just guidelines. They are not the whole truth. So definitely, although they do mention IO as a preferred therapy, but if we talk about our scenario, Indian scenario, and in general also, if we talk about CPS less than 20, yes, I would be comfortable, and I have patients on single agent pembro and they are doing well, but anything less than 20 or CPS if less than 1, I would not prefer adding immunotherapy, even if the data says so.
Okay, perfect. So we'll come to that. Dr. Sushant, I saw you.
And one thing, sir, Amish sir, I saw that their trial, at least 85% patients were PD-L1 positive in that trial also. And then also they recommend that it can be given in PD-L1 negative, but 85% patients were PD-L1 positive, and the robust effect was in their CPS more than 20. Otherwise, the patients were not performing well.
Right. So since you are on screen, tell me where would you put oral metronomic triple therapy with or without IO in this table? Sarachand is thinking. Kahan dalu, kahan dalu.
Sorry, sir, you are asking. No, sir. Just I would like to thank you, Dr. Vijay sir, again in this context that in Rajasthan there are 2-3 categories only the patients. There are one category is the government sponsored like RGHS, CGHS, Railway, ESI, and other panels where the limit is sky. And the second category is where the almost all Rajasthan is covered in Chiranjeevi and Bhamasha Yojana, where the patients are non-parents can be enrolled. And third one is the patients who are wealthier can opt any treatment. So there are hardly 2-3% patients. But as per the Chiranjeevi Bhamasha, we know the regimens which are being endorsed by the government in Ayushman. There are no immunotherapy, and the patients in this category are poorly affordable. So what we are thinking, then after the exhausting the options like paclitaxel, carboplatin from the Ayushman wall, we usually offer them that we can give you an IO plus OMCT, and it has the robust results as we have seen in our own trial of India. So, and the people are opting this very frequently. But yes, we are not giving in first line at present. We are giving in second line if the patients are not affording for the standard dose.
So first line also, I feel that it has a role, and we'll discuss. I saw Dr. Sushant Mittal join. Sushant, are you there? Sushant, I can hear you talking to some patient.
You are on the correct track.
Sushant, I think either you have to mute or you have to join the conference. Dr. Monica, I saw her there. Dr. Monica, you are there?
Yeah, I am there, sir. Can you hear me?
I can hear you now very well, Doctor. Dr. Monica, are you aware of Dr. Vijay Patil's both the papers, doublet oral metronomic therapy versus cisplatin and triplet
Yes, sir.
oral metronomic therapy plus minus IO, and that is of 20 milligram of nivolumab?
Yes, sir.
Okay, and Rajat showed very interesting slides of both. So,
Yes.
Monica, if given a choice, where would you put in this NCCN table triple oral metronomic chemotherapy alone, with or without IO?
I would put it as one of the preferred regimens, sir, because because of the
First
scenario.
line, second line, first line, second line, where?
First
Or
line.
in certain
First line.
special circumstances?
In first line,
Okay.
one of the preferred regimens. Yes, sir.
Okay, Dr. Monica, I'm sure Dr. Vijay Patil, Vanita, and Kumar would be very happy about that. Dr. Avinash, we have Dr. Avinash. Okay, Dr. Avinash, are you there? Okay, I can't say. So, Gitika, in case if Dr. Avinash joins and if Sushant is again joining, let me know. So this is the trial we had, it just published in JCO, and there was an editorial, nice 3-page editorial, which was dedicated to this study. And I think we all were very proud of this particular publication. And I feel this has revolutionized the way we are going to treat our head and neck cancer patients. And this was the 1-year data. And you can see the graph, which is separating, which is huge. 40% versus 16%. Now that is, something which at 1 year is amazing. Let's start with Dr. Tanmoy. Dr. Tanmoy.
Dr. Amish, your slides are not moving. Sorry, your slides are not moving.
मेरे कंप्यूटर में मूव हो रहा है रजत, इसीलिए मैंने बोला था कि मेरी स्लाइड आई कि नहीं गीतिका?
नहीं, अभी तक नहीं आई।
रास्ते में रहे। सर आपका वो क्या है कि ट्रैफिक ज्यादा जाम रहता है सर दिल्ली में?
नहीं यार, ट्रैफिक ज्यादा जाम नहीं है। लेट मी सी अगेन, आई विल सेंड इट अगेन। 1 minute। हाँ
सर, अगर फुल स्क्रीन नहीं हो रहा ना तो ऐसे ही मूव ऑन कर लीजिए।
नहीं बेटा, फुल स्क्रीन की बात नहीं है। कैन यू सी माय स्लाइड?
यस सर, रेस्पॉन्स रेट, द स्लाइड ऑफ रेस्पॉन्स रेट, यस।
ये दिख रहा है ना, तो अभी हम ऐसे ही रखते हैं, फुल स्क्रीन नहीं करते हैं। ओके, राइट। सो रजत, आई सॉ यू ऑन द स्क्रीन। कैन आई रिक्वेस्ट रजत टू बी देयर? Rajat Saha disappeared.
No, I am there. I'm there. I'm there.
Rajat, you presented both the papers by Dr. Vijay Patil being the first author. So help me understand, response rate of extreme trial, keynote 048, sorry, there's a spelling mistake, checkmate 141, which you presented, keynote 040, which is the pembrolizumab, and Dr. Vijay Patil. I have written that Dr. Vijay Patil's paper had 60% response rate. What are the other responses which you look at it?
60% response rates is still a little far-fetched response rates in metastatic head and neck cancer patients.
Right.
And
so,
can you hear me?
Yeah, I can hear you, Rajat. You are a little breaking, but now you are better.
So 60% response rates is still a little far-fetched. The only thing is the only caveat with the Tatopated, it is a comfortable with the multi-institutional trials. whereby we can reproduce the data in other centers also. That is one thing which I would like to say. And extreme trial and all, I don't think so. They had so high response rates. Extreme or Keynote
Dr.
048 also did not have that.
Yeah. Dr. Tarachan, do you remember the response rate of Extreme Keynote 028? And these are both in the first line, and Checkmate 141 and Keynote 040 both were in the second line.
Sir, actually, response rate usually I don't remember, but I think extreme trials response rate must be nearby to that low dose immunotherapy plus Vancomycin trial. It must be, because I am seeing in daily practice. That's why I am seeing you, because and I have seen in those both of the type patients, because we are also using the low dose immunoglobulin and same time we are giving the cetuximab combinations in a weekly basis, weekly TPX. And yes, response rate is good.
So the response rates in the extreme trial was 59% at 12 weeks. 59% at 12 weeks.
Yes, sir. That's why I am telling that it must be, I think, equal, because I don't remember the actual data.
So extreme response rate in cetuximab arm had reached 59%, but if I remember Rajat correctly, it is 37 to 38% is the highest reported response rate. Keynote 048, again, it was 42%. Checkmate 141 in the chemo refractory arm was 16 to 18%. Keynote 040 was further bad. And Tata Hospital study, even in the control arm, it was 45% response rate. And I had discussed this in OBTO platform with Dr. Kumar Prabhash, and he said, even in their previous trial of cisplatin versus doublet, they had reached the response rate of 30 to 35%. But as Rajat said, we always look at multi-institutional, the word Keynote and Checkmate are all very fancy for us. But when we have our own Indian data, sometimes, difficult for us to palate about it. Okay, so let's start.
Sir, actually क्या होता है, हलवाई मिठाई अपने सामने बनाता है ना, मजा नहीं आता.
उसको प्रॉपर पैक करके दो, एकदम ऐसा मशीन में डाल,
शोरूम में रखी हुई मिठाई पसंद आती है और हलवाई सामने बैठ के बनाता है.
So true. Dr. Tanmoy, Dr. Tanmoy, before you answer platinum refractory and sensitive, let's go forward to Dr. Tarachan. Which mithai do you like? Open खुला हुआ या foil से पैक किया हुआ? Dr. Tanmoy.
Sir, Dr. Tanmoy is not there.
So Dr. Sushant is there.
अच्छा, Dr. Sushant.
हाँ जी सर.
हाँ जी, पेशेंट से बात हो गई?
होगी सर, हो गई.
Okay,
सर मिठाई ऐसा है सर, इट डिपेंड्स कि पेशेंट की रिक्वायरमेंट क्या है. ओपन मिठाई भी जरूरत है तो ओपन मिठाई देनी पड़ेगी, अगर उसको पैक मिठाई चाहिए तो पैक मिठाई देनी पड़ेगी. अब ओपन मिठाई अगर हम देखें कि लो डोज निवोलुमैब, वी हैव आवर इंडियन डेटा, आवर colleague has presented.
Sushant, I'm coming to that. The question was not about patients. The question about what Rajat raised the issue, and what I also have in my mind, that Indians data with such good response rate, we will have skepticism. If the same thing in a Keynote 048 या Checkmate 141 में दिखाया होता, तो we would have readily accepted it. We discussed and debated about this response rate. I checked with 3-4 different people in Tata Hospital, and everybody said that it actually produces good response rate. Dr. Ankur Behel came out with a very interesting that erlotinib alone may not work, but as an anti-EGFR with IO, probably it is adding on to the response rate. So these are the things which we need to see, that how it goes. So Sushant, in your clinical practice, platinum refractory and platinum sensitive, you keep a cutoff of 6 months, or is there any other criteria?
In head and neck, I didn't know sir कि ऐसा कोई definition है. I thought only in ovary it is there, but yes, I think it's for 6 months.
So chemo refractory definition आपके लिए क्या है आपकी clinic में?
In head and neck, I think within 6 months if the patient relapses, then it's definitely platinum refractory.
Platinum refractory, right? So Sushant, you have this thing. You have a scenario where the patient is chemosensitive, relapsed after 8 months, and PD-L1 is 0%.
Yes, sir.
Okay, less than 1%, there is nothing seen. Now, what percentage of your patient, as Dr. Tanmoy mentioned, I think Tarachand mentioned, what percentage of your head and neck patients are PD-L1 negative?
I think about, sir, 40 to maybe 60% are PD-L1 negative, sir.
60% PD-L1 negative. Tarachand, how many percent of the patients are PD-L1 negative in recurrent head and neck?
Sir, I think it is only if we go with the SP263 platform, it is around 20 to 25% we are seeing which are over PD-L1 negative. Otherwise, all are the PD-L1 positive, although the score is around 1 to 2% in many cases.
1 to 2%. Dr. Monica, in your experience, how many are PD-L1 negative and how many are PD-L1 positive?
Sir, I do it in very few patients because again, the affordability issue, and I am in a region where head and neck cancer is not as rampant as we see in the north or in the west. But for whatever few patients I've done, about as Tarachand has said, the same around 20, maybe 20 to 25% are PD-L1 negative. The rest of them all are PD-L1 positive.
Okay, so Keynote 048 said that 85% of the patients were PD-L1 positive. Rajat presented that. And the TMC study, the Tata Memorial Center study, said that around 70% of their patients were PD-L1 positive. So that means 30% are PD-L1 negative. So I think what all our panelists are saying is exactly same. Around 1/4 of our patients would be PD-L1 negative and 75% or 3/4 would be PD-L1 positive. Okay, the most important question, and let me start with Sushant. Sushant, you have joined late. Sushant,
Yes,
will
sir.
you ever, if your patient is able to afford anything under the sun, and I know so many of your patients are able to afford everything, would you offer immunotherapy in PD-L1 negative patient in a recurrent head and neck cancer patients?
Yes, sir.
And so you would offer.
Yes.
Which are these scenarios where you would offer PD-L1 negative patients may IO? And I'm sure you must be offering IO plus chemo or IO alone also you offer.
Sir, it depends.
We are talking of chemo-sensitive patient right now. Remember that, Sushant. We are talking of chemo-sensitive patients.
Yes, sir. Sir, my decision not only depends on the PD-L1 report, but also on the symptom of the patient. How much is the disease burden? How much?
High volume symptomatic patient, PD-L1 negative.
So I would start on chemotherapy. If the patient is fit for chemotherapy, then chemotherapy. If the patient doesn't want chemotherapy, that we have recurrence disease within 8 months, he's elderly, we don't want to give chemotherapy. So then I would offer them immunotherapy as well. And I would give them immunotherapy for the sake that they do not want the side effects and they want the treatment to be given. But in that scenario, I would give.
Right. So, Sushant, help me understand, patient can afford anything. And you can see this red box on the screen.
Yes, sir.
In that, they have said that there is a European Medicine Agency dating October 17, 2019. And they have said that in PD-L1 negative as compared to extreme, there was 7.9 versus 11.3 months was the basically overall survival. And in Keynote 048, extreme trial से लेके Keynote 048 तक अगर आप देखते हो PD-L1 negative, the overall survival is 7.3 to 8 months के बीच में होता है. And extreme trial, if you follow extreme, consistently it is anywhere from 10.7 to 11 months. Why not extreme and why immunotherapy in PD-L1 negative patients, Sushant?
So because the cetuximab has more of the rashes and side effects which will affect the patient. The quality of life what I want to give to the patient would be better with immunotherapeutic agent compared to the cetuximab.
Patients are longer, Sushant. Patients are living longer if PD-L1 negative and you expose them to chemo plus cetuximab.
That is there, sir. Definitely that is there. So I would counsel for both of them. If they are ready to accept those things, then yes, then cetuximab can also be given.
Okay. Dr. Monica, PD-L1 negative, would you give immunotherapy to patients?
So in PD-L1 negative, I wouldn't in the first line in the metastatic setting. I would go for depending on the fitness, chemotherapy plus cetuximab would be my first choice. And if there's a borderline fitness, I would go for the weekly chemo regimens, which are like better tolerated. And in case the fitness is really bad, like cannot tolerate any chemo, then probably I would consider immunotherapy, just like how Dr. Sushant has told.
Then you would consider immunotherapy. So,
Yeah.
Dr. Monica, why not triple oral metronomic therapy if the patient is not fit for chemotherapy and PD-L1 negative? So it is erlotinib, methotrexate, and celecoxib.
Yes, that also can be one of the treatment options. Any fitness for even oral chemotherapy, I would go for oral metronomic, again, depending on the finances part of it also.
Right. Dr. Tarachand, patients can afford anything. And so you have option of giving extreme trial, you have option of giving triple oral metronomic, and you have option of giving IO alone or IO plus chemotherapy in PD-L1 negative patients. What would you choose in your
Sir, in a PD-L1 negative patient, I will use a extreme trial, not the IO plus CT, because we have seen that in that trial also the 85% patients were PD-L1 positive, and the better response was seen in CPS more than 20 only. So I will keep the reserve immunotherapy for the second line, and for the low dose immuno and plus chemotherapy, still there was a comment from the authors from the last comment from the authors of this trial was that it should be used in a low affording patients because it was not mentioned as a standard, and at the same time it was not compared to the standard 200 milligram dose.
Standard 200 milligram dose. Okay, so we will, I think we all need another this thing. Okay, fine. So this is something which is very interesting in Keynote 048. If you see PD-L1 less than 1%, the median survival was 5.7 as compared to 5.8 months. Okay, and there is another subgroup niche where the red box I have kept PD-L1 less than 1%, but P16 positive. There was 10 months with IO therapy, but only 24 patients and 10 patients were there in this trial. So I am little confused, and I don't agree with majority of you who are going to use IO therapy in patients with PD-L1 negative, because neither Keynote 048 nor in the second line setting, we have seen that IO works well as compared to cetuximab or TPX in patients with PD-L1 less than 1%. Okay. So, Sushant.
Sir, can I ask one thing, sir?
Yes, Sushant, please go ahead.
Sir, elderly gentleman, we have given radiation with cetuximab, and within 8 months, he progresses.
Okay.
And now he has high burden disease, he's PD-L1 negative, sir. So you would just offer chemotherapy?
So either weekly chemotherapy, this patient, if the patient is fit for that, or you can counsel the patient for triple oral metronomic chemotherapy alone without IO. And you see the response rate is to the tune of 39 to 45% in both the Tata Hospital trial with double and triple both. So not only you will get a good response rate, but your patient will also live little longer. And probably what nobody has explored, Sushant, but next step, what I feel Tata Hospital should do is to have a gap of radiation followed by triple oral metronomic followed by standard treatment, and see whether there is a long-term this thing is there or not. Sushant, between extreme and TPX,
sir, 1 minute. Is this patient is this patient fit for the low dose IO plus OMCT? Because the 8-month progression after the cetuximab and the high burden disease, single IO will not work in that case. And we have seen, and in my practice also, after the release of this data, we are giving IO plus OMCT low dose, and patients are getting good results in within 3 weeks also.
Correct. IO plus OMCT, Tarachand, that's what I said. The response rate is 59%, which is reported. So if this patient can be, all I said is we are talking of PD-L1 negative patients. Although the 151 was the number of patients in TMH study, there's too small number for subgroup analysis. So I cannot talk much about PD-L1 negative versus PD-L1 positive. Tarachand, in your practice, extreme versus TPX, what do you follow?
Sir, I am following TPX only. Extreme, I think, has toxicity, more toxicity, and I think it is not good to give to keep admitted patients for 5 to 6 days, and when we are not giving us extraordinary survival. So it is better to give and usually we are following the weekly TPX modified version of India, that so that the patient does not have and may not have experience of the docetaxel side effects of the febrile neutropenia, and patient can come comfortably. And in this also the patient has to come for cetuximab at least weekly for 3 months, then we can combine it without adding another toxicity.
Right, absolutely right. Dr. Monica, what do you practice? Extreme TPX or the modified version of weekly TPX, as Tarachand mentioned?
Weekly is a little difficult in my center, weekly admissions, because of some logistic problems. So I prefer to give 3 weekly unless there is a borderline for weekly regimen, would go for weekly TPX.
Right. So we had a survey done in Indian medical oncologists, and I think 90 to 95% of patients, they prefer TPX over extreme. And I think that is what we practice. So my point was that in head and neck cancer, the NCCN guidelines probably is not for us. And that is what I wanted to highlight. So in a patient who is PD-L1 negative, and if you have decided not to give IO, you have 2 options. One option is you give TPX or extreme or triple oral metronomic chemotherapy with or without IO. I think that is what it is there. Dr. Monica, patients in the second line, you have, for example, you have given extreme or you have given TPX and patient progresses. After that, what do you do?
Triple oral metronomic is one thing which I would consider, sir, with low dose nivolumab, if I've given TPX in the beginning. And single agent IO is also something which I would consider in the second line.
Single agent IO also, which you will consider in the second line. Checkmate 141 did not differentiate between PD-L1 positive and negative. So you are right, Monica. In the second line, either triple oral metronomic with IO, without IO, or IO alone also you can give based on the volume of the disease which is there. So if PD-L1 is positive, let me straight away jump to Sushant. And please, Gitika, anybody, I think I have 3-4 more minutes. And if any panelist who has joined and I have missed out, please let me know.
Sir, Dr. Abhinav Jawad.
I think Gunjesh is also there, right?
Gunjesh and Avinash. So let's focus 4-5 minutes on them.
Rockstar of Ranchi, sir. Gunjesh.
Dr. Gunjesh, Ranchi के कौन? वरुण धवन हो गया या फिर क्या हो गया? विराट कोहली हो गया रांची का? Gunjesh, can you hear us?
Sir, he is not there. Only Dr. Abhinav Jawad is there.
Okay, Dr. Avinash, can you hear me before Gitika again says that he is not here?
No, sir. Yeah, I'm there, sir.
He's Abhinav, sir.
Abhinav, sir.
Okay. Dr. Abhinav, if PD-L1 is 2%, if PD-L1 is 2%, patient is platinum sensitive or chemosensitive disease. NCCN guideline says that you can give IO alone also because it is non-inferior to chemotherapy, or you can give IO plus chemotherapy. Do you agree with that Keynote 048 data of this? Or you think that the Keynote 048 is guided by PD-L1 more than 20%?
So I think it is I would consider IO plus chemotherapy single agent IO, I would not consider in a patient with PD-L1 2%.
So Abhinav, if the patient is not fit for chemotherapy, but still chemosensitive, would you give single agent IO? Would you give single?
Yes, if patient is not fit, then yes, definitely. So I will give single agent. If patient is not chemo fit, then I'll definitely give IO single agent. That's like 2% PD-L1 I'll give.
Okay. We discussed about that. So this is the last point which I want to discuss in next. And let me start with Tarachand. Tarachand, patient is chemo refractory. And if PD-L1 is more than 20%, what would you do?
Sir, IO plus CT.
PD-L1 more than 20%, also IO plus CT. Patient is chemo refractory. Which chemotherapy would you give?
Sir, chemo refractory, but if the patient is having low volume disease, then can offer the single agent immunotherapy. But still, if the patient has high burden disease, then I have to combine with the chemotherapy. Even we can try with any other platinum combination. Even patient is platinum refractory. We have seen some results in some patients because the immunotherapy takes time to act. It is around 1.5 months to 2 months. So meantime, patient may progress a little. That's why I want to combine.
Right. So Tarachand, do you remember the exclusion criteria of Keynote 048? They did not have a single chemo refractory patient. All patients were relapsed more than 6 months after the last treatment, right?
Yes, sir.
So all the data of PD-L1 more than 20% is in chemosensitive. We don't have any data of using IO and platinum refractory. Or do we have the data? We have the data here, that is Keynote 040. Where they had included both the patients, and here they found that if the PD-L1 TPS is more than 50%, then you have 11.6 months is the overall survival compared to 7.9 months. Otherwise, PD-L1 CPS more than 1%, just single agent methotrexate is giving you 7.1 months compared to 8.7 months. Why waste patients' money on that, Tarachand? I still can't understand. Why are we so IO and IO?
Sir. No, sir, IO, because if we are excluding the IO, then we only Indians have the option of OMCT because no one have the option of OMCT in their guidelines. The only left
Sushant, in your clinical practice, where have you incorporated OMCT?
Sir, OMCT, मतलब oral metronomic chemotherapy, na sir?
Yes.
Oral triple metronomic chemotherapy, erlotinib, celecoxib, and methotrexate.
That's 80% of my patients are on OMCT.
80%. Wow, that's
Yes,
great. And have you started using nivolumab 20 mg?
Nivolumab in?
Have you started adding nivolumab 20 mg in this triple OMCT?
If the response rates are not as good as expected and patient want further responses, then yes, after counseling them.
Okay. Dr. Abhinav, the 12-month overall survival data by just adding 20 mg of nivolumab was 40% as compared to 16% at 1 year. And according to Dr. Kumar Prabhas, there are still 17 patients, 75 in each arm. 17 patient happens to be 15 to 17% patient which are still continuing on nivolumab 20 mg. Abhinav, don't you think that that is a very good option in a patient who is chemo refractory? Dr. Abhinav?
Sorry, sir, I got disconnected. Can you repeat the question, sir?
A patient who is chemo refractory,
yes, sir,
and receives triple oral metronomic chemotherapy plus nivolumab of 20 milligram.
Yes, sir.
The 1 year overall survival is 40% as compared to 16% in only this comparative arm. And almost 15% of patients are still on nivolumab at the end of 1.5 or more than 1.5 years. Abhinav, why shouldn't we incorporate this protocol in our day-to-day practice, at least in chemo refractory patients?
Yes, sir, definitely. After that trial, we like, at least I have started using IO plus OMCT, in almost all the chemorefractory patient. Only issue with which I am facing is the finances. Although that 15,000-20,000 is also a expensive thing, at least in our setting. But otherwise, yes, I tend to use IO plus OMCT in chemorefractory setting. And even if it is PD-L1, like if PD-L1 strong positive, if they're not affordable in the beginning, later lines, I try to use IO plus OMCT. Definitely, sir.
That's great. That's great. I think we have to, at least I feel that in a chemorefractory patient, triple OMCT plus IO happens to be one of the best option our patients have today in terms of response rate, also in terms of overall survival. Dr. Monica, PD-L1 90%, 90%, and MDM2 4 positive and KRAS positive on NGS. Would you give single agent pembrolizumab to your patient? Or you think the data is not mature for you to understand that?
Sir, risk of hyperprogression is something which is seen mostly in patients with MDM2 positivity. That's what was discussed earlier, right? So
Right.
if at all the disease is such that hyperprogression will have a significant risk to life, like compression of airway or
would you give to patient comes with NGS report, PD-L1 is 90%, MDM2 4 methylated, and patient has KRAS mutation also. Would you give pembrolizumab to that patient or not? PD-L1 90%, 90%.
PD-L1 90% looks very attractive, sir, to give pembrolizumab. But yes, I'll just keep a very close track of the risk of hyperprogression in view of MDM2 positivity. So I would monitor very closely.
You are absolutely right, and you would explain to the patient. At the same time, you don't want to miss the bus of giving pembrolizumab to PD-L1 90%, and there is nothing written in stone that every patient of MDM2 would have a hyperprogression. So just to conclude, there are three take-home points I wanted the panelists to take, or all the audience to take. One is that in PD-L1 negative or PD-L1 0%, I'm not very convinced whether IO works in first line or second line. TPX is something which we should use, and 90% of medical oncologists are using TPX either weekly or 3 weekly, how it is given. In PD-L1 positive patients, more than 20%, more than 50%, yes, you are justified in using IO. But between 1 to 20%, please remember you have triple OMCT with IO data, which is coming up in a very nice way. I'm waiting for 2-year survival data also, which will mature that data. And the last point is, in a chemorefractory patient, please read the full paper of TMC. I have the full paper. Please drop me a DM and I'll send you the full paper. Triple oral metronomic chemotherapy with or without IO actually is a very good and one of the best option today what we have if the patient is chemorefractory. And with that, I would close my panel, and thank you so much, Tarachand, for giving me this opportunity. If any burning question, I'm ready to take. Otherwise, we should move forward. I'm already exhausted past my time.
Thank you, Amish sir. You have taken nice class on the head and neck cancer, and I think in a locally advanced metastatic, I don't think any stone is unturned till now, and you have touched the every point. Thank you, sir.
Thank you so much. Thank you.
Now the next session is ovarian cancer, and I would like to invite Dr. Advait Gaur. He is Associate Director Medical Oncology, Nanavati Max Institute of Cancer Care, Nanavati Max Specialty Hospital, Mumbai. He will be speaking on the CIPLA sponsored session, bevacizumab combined with platinum-based chemotherapy in patients with primary or relapsed ovarian cancer. Dr. Advait Gaur, please.
Yeah, thank you. If I can share my screen, can you allow me? Yeah, sure.
Yes, sir, you can.
Sure. Thank you. Thank you very much. So today, the task given to me in next 15 minutes is to touch upon how we combine bevacizumab with platinum-based chemotherapy in primary or relapsed ovarian cancer. I think this is a very interesting topic, but most of the science has moved ahead from just combining bevacizumab to looking at mutation testing and germline testing, and then having a genomic-based therapeutic approach, which we currently follow. So we know that advanced ovarian cancer is a very, very aggressive disease. And I would start my talk initially by speaking about combination chemo plus Bev for patients with recurrent ovarian cancer first. And these are the three main studies which have looked at what is the evidence for using bevacizumab along with chemotherapy in a platinum-sensitive recurrent ovarian cancer, as well as platinum-resistant ovarian cancer. We have the GOG 213 and the OCEAN study, which have evaluated the combination in platinum-sensitive disease, both with different combinations, one with a taxane platinum combination, the other with gemcitabine and carboplatin. And the Aurelia study, which has looked at platinum-resistant ovarian cancer patients, which are treated either with chemotherapy or chemotherapy plus bevacizumab. So OCEAN study looked at GemCarbo plus Bev versus GemCarbo alone, and this was the investigator-assessed PFS. This is at the data cutoff in 2010, median PFS of 8.4 months with the placebo and 12.4 months with the bevacizumab arm, a significant hazard ratio. Overall response rate and duration of response also was better with the bevacizumab arm, with the overall response rate being 79 to 80%, and the median duration of response being almost 10.5 months. This was the final overall survival analysis, which was published in 2015. The median overall survival with combination of bevacizumab was 33.6 months as compared to the placebo with 32.9 months. And this is essentially because crossover was allowed in this study. There were no new adverse event signals which were noted. We all know that hypertension, patients developing venous thromboembolic events, or patients who are developing GI perforations rarely. These are all common complications of bevacizumab, which most of us do manage and monitor very regularly. Proteinuria is something which we need to really carefully monitor in this group of patients. The next study was the GOG 213 study, which looked at paclitaxel carboplatin versus paclicarbo and bevacizumab. This also had a maintenance bevacizumab arm in which the bevacizumab was continued until disease progression. And here we see in terms of the combination arm, the progression-free survival is 13.8 months versus 10.4 in the chemo arm alone, which is also showing statistical significance. The overall survival, 42.2 months with the combination as compared to 37 months with the chemo alone group. Similar kind of adverse events were noted, and this is what we see across clinical practice also. The Aurelia study looked at platinum-resistant recurrent ovarian cancer. These were patients who were looked at chemo, who were randomized to either chemo or versus chemo plus Bev. And the investigators were free to select between any of these chemotherapies, either a weekly paclitaxel or topotecan weekly, or PLD given once in every 4 weeks. The Aurelia study also confirmed that addition of bevacizumab to chemo was better in terms of the median PFS, the median overall survival, as well as overall response rates. These were the cohorts treated with paclitaxel, and we see that the paclitaxel plus bevacizumab median PFS reaches to almost about 10.4 months and overall survival close to 22 months. With topotecan, the results are not as great as what we see with paclitaxel. With PLD, again, not too much of a combination which is really working in terms of PFS benefit in this heavily treated patients. Again, the adverse events, mainly hypertension, proteinuria were the common, delayed wound healing and arterial venous thromboembolic event in very few of the patients. So coming to the next development, which was in bevacizumab plus chemo for the newly diagnosed advanced epithelial ovarian cancer. And this naturally is seen in every drug journey, that initially the drug gets approved for an advanced disease, and then we try and use the same drug in an early stage of disease. So this is a case that I just need to put, which is a 59-year-old female with stage 3C ovarian cancer who initially presented with early onset satiety and abdominal bloating and discomfort. She was postmenopausal with unremarkable past menstrual history. She had no habits. On physical examination, she had abdominal distension with left lower quadrant tenderness on palpation and some shifting dullness, which was noted. Clinical workup revealed that there was a left ovarian mass. CT chest abdo-pelvis revealed a left adnexal mass, which was about 5 centimeters in size. There was extension of these deposits right up to the liver capsule, though there was no involvement of the liver. And there were retroperitoneal lymph nodes and ascites, which was noted, but there was no pleural effusion. A lymph node and adnexal mass biopsy was done, and about 2 liters of fluid was removed, which was sent for cytology, and all these confirmed a high-grade epithelial ovarian cancer. So with the diagnosis of a stage 3 or an advanced disease, we further proceeded to do the germline or molecular testing, which showed that the HRD and the BRCA were both HRD was negative and BRCA was wild type. The CA-125 baseline was 385 and she had a PS1. She underwent a TH plus BSO plus lymph node dissection with optimal debulking, and the surgical oncology team at our center were able to achieve an R0 resection. And we followed this by intravenous paclitaxel plus bevacizumab every 3 weekly, not to use the bev for the first dose. We used it from the second cycle onwards, and this was followed by bevacizumab for 6 cycles. Now, this patient is still on treatment. There was a complete response, and post-treatment CA-125 was 48 at the end of 6 cycles. Continued BEV, 3 months post-treatment, the CA-125 is 30, scans are normal, and so is the clinical examination. So currently, if we look at the standard treatment for newly diagnosed, we know that for stage 4 disease or for large volume residual disease patients who undergo suboptimal surgery, combination of chemo plus bev is preferred. This is on basis of the GOG 218 and the ICON 7 very landmark trials. But this decision also depends on insurance reimbursements as well as cost effectiveness, which remains challenging. So angiogenesis as a target, there have been multiple different phase 3 studies which have shown. We just discussed about the OCEANS, the GOG 213 and the Aurelia study. Now we focus on to the GOG 218, which looked at addition of bevacizumab in primary therapy, 3-arm study, paclitaxel with placebo, paclitaxel with bevacizumab, which is to begin at cycle 2 without the maintenance, and paclitaxel bevacizumab with maintenance were the 3 arms, almost 1,870 patients. And these were the investigator assessed PFS, which were favoring the concurrent chemo plus bev followed by maintenance arm, with a median PFS of about 14 months. So they looked at different factors which were sort of surrogate markers. Impact of using CA-125 as a determinant of PFS. It did show that CA-125 decrease was much more faster with the concurrent chemo and bevacizumab arm, and this was statistically significant. Overall survival, this was at the time of primary analysis, which was published in 2011, also showed that the overall survival was not much different between either group, whether we use the chemo, the bev as concurrent or concurrent followed by maintenance. Adverse events were also the similar. Ascites and ascites, rapid decrease in ascites did show that the treatment would benefit these patients. 80% patients had ascites and peritoneal fluid more than 50 cubic meters. That was the one which was evaluated, and the median PFS was better in patients who had ascites. When we look at certain other markers which were assessed during the study, these were of course published later on. This was in 2017 paper which looked at microvessel density and the tumor VEGF and the PFS benefit. The maximum benefit was seen in patients who had high microvessel density with the concurrent as well as maintenance strategy. This was the final analysis of the GOG 218. This was in JCO 2019. The survival advantage was seen only in stage 4 patients. This is the graph E which mentions, otherwise all the curves are almost overlapping. And this was only in the group where BEV chemo concurrent was used, followed by BEV maintenance. where we see straight away almost a 10 months median overall survival difference, 32.6 and 42.8. We moved to the ICON 7, which was again a similar kind of study. Bevacizumab was given concurrently for 5 cycles followed by 12 additional cycles. In some patients, this was continued until progressive disease. We see here that in terms of median PFS, addition of bevacizumab led to a PFS advantage of about 2 months. In terms of final overall survival, they were almost the same. If you look at the subgroup analysis, based on the subgroup analysis, patients who underwent suboptimal surgery and patients who had stage 4 disease were the ones who derived maximum benefit. The final PFS in this high-risk group, which was looked at patients having stage 4 disease or patients having suboptimal cytoreductive surgery, the combination showed that there was a 6 months PFS advantage of using bevacizumab. And in terms of overall survival, this translated to almost a 10-month survival advantage. So the important messages from both these studies, for my understanding, is that patients need to be stratified. Who do we call as high-risk patients? Patients who had suboptimal resections for stage 3 disease, patients who have bulky residual disease, or those with stage 4 disease. They are the ones who appear to have the most benefit of incorporation of bevacizumab along with chemo and continuing bev maintenance. The updated data in 2019 for the GOG 218 showed a 10-month difference. So in these high-risk patients who look like they have bulky disease, we should be incorporating bev into the treatment. So these are the high-risk subgroups, as I mentioned. Naturally, then the thought comes in whether we should be using bev plus chemo in the neoadjuvant setting and look at a situation where we are using it before interval cytoreductive surgery for patients who are not fit to undergo upfront primary cytoreductive surgery. We touch upon those, but of course there is no level 1 evidence for that. There are multiple phase 2 studies which have looked at. This is the largest one, the GECO 1205 study, which was a randomized phase 2 trial of neoadjuvant chemo with without bev. And the conclusion was adding 3 to 4 preoperative cycles of bev to neoadjuvant chemotherapy for unresectable disease did not improve the macroscopic response rate or surgical outcome, but it improved the surgical operability without increasing toxicity. The same conclusions as the GECO 1205 were seen from the Antalya trial, as well as this subgroup analysis of the MITO16A MANGO study. So today, when we decide about what treatment pathway for a newly diagnosed advanced ovarian cancer, we look at somatic BRCA testing, look at HRD testing simultaneously. We took a first decision to be made is whether this patient is fit for primary debulking or primary cytoreduction surgery or neoadjuvant chemo. The second decision is whether we add bevacizumab to paclitaxel carboplatin. If we are not going ahead with bevacizumab, then the next decision would be whether to add PARP inhibitors, whether the bevacizumab needs to be added during chemo or in maintenance. And naturally, based on the BRCA status and the HRD status, addition of a PARP inhibitor can be done. So in conclusion, the addition of bev maintenance to frontline chemotherapy results in about a 4-month increase in PFS. Survival advantage is most pronounced in high-risk group. The GOG 213 was the only study to show an overall survival advantage of incorporating bev to standard treatment regimens. In Aurelia, the largest survival benefit was seen with the weekly paclitaxel plus bev group, which suggests a synergistic response between both these agents. There also may be a survival advantage to continue bevacizumab beyond progression or re-administering bevacizumab treatment, and prior bev in upfront setting should not actually preclude bevacizumab if patient has a recurrent disease later on. Currently, the PARP inhibitors are also approved for use as maintenance, but there are multiple studies looking at combination of bev plus PARP inhibitors and also immune checkpoint inhibitors. And there is early data which shows that therapeutic effect will be synergistic. Commonest toxicities are hypertension and proteinuria, and there are no dose adjustments for bevacizumab. Unfortunately, there still remain we still lack any prospectively validated biomarkers for the response to BEV. And possibly in early stage or in patients who are undergoing optimal surgery, we may be looking at treating a minimal residual disease in ovarian cancer, where an optimal surgery, chemotherapy, or a tumor reduction followed by maintenance therapy can be looking at a minimal detectable threshold of disease and look at MRD monitoring to improve outcomes and may even lead to cure in many of the ovarian cancer patients. Thank you all.
Now, my wonderful wife.
Tarajan sir, are you there?
Geetika, if there are any questions, I'll take it, or we pass it on to the next session.
Thank you, Advait sir. Thank you. So I would like to invite Dr. Tarachan sir for next session.
Thank you. I start my 1 minute. Lisa, okay. Just share 1 minute. Yes. Are my slides visible?
Sir, yes.
Yes,
can
sir.
you
Just
please
make it full screen, sir.
Yes. So my topic is, this is AstraZeneca sponsored session, bringing precision to medicine to newly diagnosed ovarian cancer. We know that the ovarian cancer is among the common cancers of India. Around the 70% of the advanced ovarian cancer patients relapse within 3 years. So we need a better drug to overcome this gap. And we know that the advanced ovarian cancer is characterized by the multiple relapses, that PFS1 is usually 12 to 24 months with the current line of chemo plus minus bevacizumab, and then it becomes subsequently lower with the PFS to 8 to 20 months and the 4 plus months, and then so on, decreasing every time at every relapse. So usually we know that whenever the ovarian cancer, if it is relapsed, then is usually incurable. So we need to optimize the first line treatment so that relapse time can be better. So we see that how that the ovarian cancer first line management has been progressed. From in 2003 it was chemotherapy, but for the 8 years it was only the chemotherapy. Then the bevacizumab came to improve the PFS. And 2018, yes, it was the PARP inhibitor who targeted genetically the ovarian cancer and BRCA mutations, and it was the solo one. And then 2019, if we come, we can have a combination of bevacizumab plus olaparib as PAOLA-1. So how the cancer is formed, that we can say that whenever there are different pathways are activated by the DNA damage usually, and if these pathways are not activated, then cell become the cancers. Then these inserts may be the external in the form of radiation, chemotherapy, and others, or the single strand break repair, base repair, then it is repair by the base excision repair and DNA glycolysis pathway. And PARP1 is essential for the base excision repair. And the double strand break repair, then maybe the homologous recombination, non-homologous, and these are the BRCA1 and the BRCA2 are the most common mechanism to repair by the homologous recombination pathway. And the end results become the minor DNA repair or the major DNA repair. And lastly, it goes up to the apoptosis and prevention of carcinogenesis. Usually, all the forms of ovarian cancer are having in the 50% cases HRD positivity is there. Out of these, the 20% are having BRCA mutations, and rest are the HRR gene mutation or altered HR gene expression and other unidentified causes. So it accounts total around 50% of all all ovarian cancers. The PARP inhibition that it targets the homologous recombination, that's true, by the exploiting synthetic lethality. The normal cells usually have the DNA repair mechanism by homologous recombination and base excision repair, and that leads to the cell survival. And the homologous recombination deficient cell survive by the base excision repair, and PARP inhibited cells survive by the homologous recombination. But if the patients have homologous recombination deficiency and the cells have PARP inhibited, then yes, both of these mechanisms are lost, and it leads to the cell death. So the homologous recombination proficiency is important for the normal cell function and homologous recombination deficiency. How can we identify the homologous recombination deficiency? Either we can look for the cause of HRD by the genomic changes, or the assessment of the cause of HRD by looking the loss of function by the key HR gene on BRCA and HRR genes mutation as. And or we can see by the look for the effect of HRD that leads to ultimately the genomic instability, and we can test it by the genomic instability test that may test the loss of heterozygosity, telomeric allelic imbalance, and large scale state transitions. So HRD genomic instability testing has the potential to identify more women which had HRD than alone HRR kernels. So blood germline mutation, 15% patients are BRCA mutated, and tumor, it is 20% or somatic tumor, it is BRCA mutated 20%, HRR mutations are around 31%. So genomic instability, we can find at 50% of the patients are assessing the tumor. ESMO guidelines also recommend for the HRD testing to identify most patients, so that the patients can get the benefit from the PARP inhibitors. The validated methods to test the HRD in ovarian cancer, either the tumor BRCA mutation that detects the presence of BRCA mutation, or genomic instability that can be tested by the myRAD MyChoice genomic instability test that detects the loss of heterozygosity or telomeric allelic imbalance or large scale transitions. So before considering the PARP inhibition, we should think about some consideration or facts before taking into account. The one is the BRCA patient is having BRCA mutation or wild, or HRD positive or negative. Second, patients is bevacizumab indicated or contraindicated. And third one is the clinical characteristic like stage, neoadjuvant chemo versus primary surgery, residual tumor, platinum sensitivity, and expected toxicity. So for the olaparib maintenance, this was tested in 2 trials, SOLO-1. In this trial, it was tested along only the olaparib, and PAOLA-1, it was along maintenance along with the bevacizumab. In this case, patients were taken either BRCA mutated or non-mutated. Both categories were taken into account in the PAOLA-1, while SOLO-1 was for the only BRCA mutated patients. So this was the SOLO-1 inclusion criteria, where patients were taken newly diagnosed, FIGO stage 3-4 high-grade serous or endometrioid, ovarian, primary, peritoneal, or fallopian tube cancer, germline or somatic BRCA mutated, ECOG performance status 0 to 1, cytoreductive surgery, or in clinical complete response or partial response after platinum-based chemotherapy. So patients were randomized after the platinum sensitive, after the completion of primary treatment. into the olaparib 300 milligram BD and 2:1 fashion in comparison to the placebo. So study was continued till the progression and with no evidence of disease at 2 years, and olaparib was stopped. And patients with a partial response at 2 years could continue the treatment. So primary endpoint was the investigator assessed progression-free survival. Other endpoints secondary were the PFS using blind independent central review, PFS2 overall survival, time from randomization to the first subsequent therapy or death, time from randomization to second subsequent therapy or death, and health-related quality of life. So the progression-free survival in the solo one, you can see that the usually at the 3 month we can see there is a how the curves are starting separating, and it was the median PFS that was observed in the olaparib arm. It was 56 months, and that is around gap of 42 months with the placebo. In the arm, it was 13.8 months with a hazard ratio of 0.33, quite impressive. For the PFS2, it was in the olaparib arm, it was not reached while it was 42 months in the placebo arm, and for the time to second line subsequent treatment, also better in the olaparib arm with the hazard ratio of 0.6. The solo one, the overall survival at the end of 7 years, it was meaningful, where we can see at the 7 year, the difference in the overall survival was 67% versus 46.5%, around 20% more in the olaparib arm, and it was not, median OS was not reached, while it was 75.2 in the placebo arm. So 44.3% of patients in the placebo group received a subsequent PARP inhibitor therapy, compared with the 14.6% of patients in the olaparib group. The most common adverse events were the nausea is the most frequent order that is experienced in the 77% patients in the olaparib arm, and second most, and after that it was the fatigue and vomiting. The most hematological toxicity was the anemia, around 40% patients, and we can see the constipation, diarrhea, arthralgia, and neutropenia was also observed. But the MDS AML incidence was around 1%, that is the most fatal toxicity after the 5-year follow-up in the solo one. The Paula one, it was the trial where patients were evaluated for the non-BRCA mutated patients. BRCA mutation was not the eligibility criteria for this trial. Their patients were FIGO stage 3-4 high-grade ovarian cancer, serous or endometrioid, or non-serous. That means BRCA mutated or not. Surgery upfront or interval. Platinum taxane-based chemotherapy, 3 or more than 3 cycles of bevacizumab. Patients were randomized to the olaparib in 2 years and plus bevacizumab for total 15 months in the 2:1 fashion, along with the randomized the comparator arm was the bevacizumab for the 15 months and placebo for 2 years. Primary endpoints were the investigator assessed progression-free survival and sensitivity analysis by the blind independent central review. Secondary endpoints were time to the first subsequent therapy, PFS2, PSST, overall survival, safety, patient-related outcomes, and health-related quality of life. Pre-specified exploratory analysis, PFS in predefined subgroups, including tumor BRCA mutated and myeloid my choice CDX test positive. The characteristics of this trial was representing the first line of patient population, unselected by the biomarker status and surgical outcomes and platinum responses. Pre-specified biomarker assessment, pre-planned subgroup analysis by tumor BRCA mutation, HRD positive and HRR mutation positive status. Active maintenance bevacizumab, only phase 3 study of a PARP inhibitor with an active standard of care comparison. Progression-free survival in Paula 1 was 22.1 month in olaparib arm, while it was 16.6 month in the placebo arm with a hazard ratio of 0.59. Primary endpoint, it was the progression-free survival. Median time from first cycle of chemotherapy to randomization was 7 months. So this was the pre-specified subgroup analysis, and we can see that the benefit of the PFS was observed in all the subgroups, irrespective of the age, fever stage 3 or 4, where a cytoreductive surgery with a R1 or R0 or R2 on time of cytoreductive surgery and response to the first line chemotherapy. The benefit was observed in all the subgroups. So HRD status, you can see around the PAOLA-1 trial, around the 48% patients were the HRD positive. Out of this, tumor BRCA mutation was positive in 29%, and genomic instability score 42 or more was in around 19% of patients. So PFS in HRD subgroup. So patients with the tumor BRCA mutation positive, it was around 15.5 months, a difference in the PFS, while HRD positive, it was around 19.5 month difference from the comparative arm and the PFS. So PFS and HRD subgroup, as we discussed last, 37.2 versus 17.7 months. At 1 year, it was 89% versus 71% PFS difference, and at 2 years, it was 66 versus 29, around 37% difference was there. And HRD positive patients, it was 28.1 month PFS in olaparib arm, while it was 16.6 month in comparative arm. PFS2 was also impressive. It was around 36.5 month PFS2 in olaparib, and it was 32.6 in the placebo arm with the hazard ratio of 0.78. 27% of patients in the placebo arm and the 9% in the olaparib arm received a PARP inhibitor as their first subsequent treatment. PFS2, we can see that all HRD subgroups, PFS2 was better in the olaparib arm in comparison to the placebo. Irrespective of the risk category also, either it was high risk or low risk category, but the patients are having HRD positive, then the patients are having PFS benefit in the olaparib arm, PFS2. A significant delay in time to second subsequent therapy supported the PFS to benefit seen with olaparib plus bevacizumab versus placebo plus bevacizumab. Around it was time to second subsequent therapy was 38.2 months, while it was 31.5 months in placebo arm with a hazard ratio of 0.78. Overall response rate was also better in the olaparib arm, and if we go with the HRD status, that is also a significant, quite significant difference with the placebo, with the comparator arm, 64% versus 42% in BRCA mutated, and HRD positive was 53 versus 31%. At the final PFS analysis, median PFS was almost 4 years in the olaparib plus bevacizumab arm for HRD positive patients. Around PFS was 46.8 in the olaparib arm and 17.6 months in the placebo arm. 5-year PFS percent was 46.1 versus 19.2. So hazard ratio was 0.141. So the addition of olaparib to the bevacizumab prolonged the overall survival, irrespective of the BRCA status. It was the median OS was 75.2 months in olaparib arm, while it was 66.9 months in placebo arm, and the 5-year OS percentage was 73.2 versus 53.8 arm. In the HRD positive, it was 54.7 versus 44.2, and HRD negative it was 25.7 in olaparib arm with hazard in placebo it was 32.3. In PAOLA-1, treatment-related adverse events, the median duration of treatment with olaparib was 17.3, and it was 15.6 months in the placebo arm. All grade adverse events were around quite same, 90 or more than 95%. Yes, grade 3% was a little bit higher, 57%, but it's 51. But leading to a dose interruption of the olaparib, it was 54%. And leading to the dose reduction around in the 41% patients, and in 20% patients, olaparib was discontinued because of the side effects. So treating the non-BRCA mutated patients, the PAOLA-1, the adverse event profile, as it is quite characteristic of the olaparib, as we see in the SOLO-1, nausea, fatigue, and you can see the hypertension as the characteristic of bevacizumab. and anemia, lymphopenia, constipation, and proteinuria because of the bevacizumab combination. The no new safety signals were observed with the long-term follow-up with the olaparib in the PAOLA-1 trial. So the most troublesome effect, which is most characteristic of this olaparib, is the MDS, but it is not so quite high and not significantly different from the placebo arm. It is at the 5-year end, it is around 1%, and no new primary malignancies were around only the 1.3% in olaparib arm, while it is 1.1% in the placebo arm. So 1.1% MDS and less than 1% in the placebo arm. No clinically meaningful or significant difference in health-related quality of life was seen in PAOLA-1 in olaparib comparison to the placebo. So takeaway messages: HRD scar test is a new breakthrough test. It's a key biomarker for predicting PARP inhibitor response in the first-line maintenance. SOLO-1, that is the 7 years update, clinically meaningful OS at 7 years, 45% reduction in risk of death. At 7 years, 67% of Lynparza patient, olaparib patients were alive. Median PFS was 56 months on the olaparib arm versus 13.8 months for the placebo. PFS at 5 years, it is 48 versus 21% for the olaparib versus placebo. Maintenance olaparib showed the 67% reduction in the risk of disease progression or death. And the PAOLA-1 5-year overall survival, addition of olaparib to the bevacizumab provided a clinically meaningful improvement in OS in HRD positive patients, regardless of BRCA status. At 5 years, 65% of patients receiving olaparib plus bevacizumab versus alive, and 38% reduction in risk of death for olaparib plus bevacizumab versus bevacizumab alone. And olaparib added to bevacizumab substantially improved the progression-free survival versus bevacizumab alone with a median PFS of almost 4 years. So HRR and HRD or genomic instability are not interchangeable and should not be considered as substitute for each other in clinical practice for first-line maintenance in ovarian cancer. Thank you. So if no question, then we can move forward. I invite Dr. Rajat Bajaj. He is a senior consultant, medical oncology, Fortis Hospital, Noida, for the management of advanced ovarian cancer 2022 and beyond. Dr. Rajat Bajaj.
Yeah, good evening. Am I audible?
Yes, sir, you are audible.
Okay. Once again, good evening, everyone. I thank the organizers, Dr. Gupta and his team for having me here, and I congratulate them for organizing this wonderful event over a big event over 4 days, where almost everything, the length and breadth of the oncological updates is being covered. And I've been listening to the last few talks, and I believe that these few talks have made my job easier to discuss about the management of advanced ovarian cancer in 2022 and how do we really take forward these new updates when we move to the next year and beyond. That is what we are going to discuss. So like I said that the part of my talk has already been covered in the last 1 or 2 talks. So most patients with advanced ovarian cancer, they relapse after following their first-line multimodality treatment. We do know that most of our Indian patients, about 65 to 70% of them, will present to us in the advanced stage, which is stage 3 and stage 4 of ovarian cancer. 70% of the women relapse within 3 years, and out of these 3 years also 50% will relapse within the first 18 to 20 months. That is why the 5-year survival still after a long deliberation and a lot of scientific evidence also still remains dismal. So there is an unmet need to improve this overall survival, and this is what we are aiming at. If we talk about the easier part of it, that is, we as medical oncologists do know that what exactly is the chemotherapy to be given in ovarian cancer, but how did it really start? Was that very simple from the very beginning, taxane and platinum? Probably no. 1998 was ICON 2, where carboplatin was pitched against the combination of CAP, which is endoxin, adriamycin, and platinum, and it was seen that carboplatin did enough compared to CAP, and it was comparable in terms of efficacy. Then came ICON 3, where platinum was pitched against a taxane platinum, and was found that taxane platinum did better in the adjuvant setting in ovarian as compared to only platinum, and that is how we had our favorite combination of paclitaxel and carboplatin for the adjuvant setting in ovarian cancer. Then there have been other trials where taxane and platinum have been thought of to be a little insufficient, and probably an addition of a third drug may improve the efficacy, but then it hasn't really seen the light of the day. So addition of gemcitabine or topotecan has not really been able to tip taxane and platinum to the post. Taxane platinum still remains a very standard regimen for us for adjuvant treatment of ovarian cancer. So after talking briefly about how we really evolved in terms of our adjuvant chemotherapy in ovarian cancer, I talk about how do we go about choosing our first line therapy in patients, especially who are optimally cytoreduced, R0 resection, upfront cytoreduction. So, of course, we do know our bevacizumabs and our taxane and platinums, but not to forget, one thing is very important, that the standard systemic therapy for a patient who is optimally cytoreduced and with the residual disease of less than 1 centimeter still remains intraperitoneal chemotherapy. Agreed that I am using it very less. My audience also would say that we are using it rarely. But then one has to remember that there is good scientific evidence behind the IP therapy. Once we talk about post-surgery, the importance of chemotherapy is very important to not let the disease come back. And these are the large IP trials that we are all aware of. And the most important in the landmark study is the one which is written at the bottom, which is the GOG 172, where more than 400 patients were randomized to receive either the IV control therapy or the IP regimen, which was the experimental arm, and look at the results. The results are certainly in favor of the IP regimen, whereas if we talk about our gold standard endpoint being the overall survival, 66 months versus 50 months, and the hazard ratio of 0.75 and the p-value being statistically significant. So IP therapy definitely is a very important therapy, and one should make use of it more and more. Of course, fit patients, about 40% of the patients could not complete this study of GOG 172 in the experimental arm. But then if we have fit patients, we should go ahead with the IP therapy. Talking about the IP still, talking about GOG 252, it was IV versus IP, but all the arms had bevacizumab. And here we saw that if we are talking about IV plus intraperitoneal, along with bevacizumab in both the arms, the difference between IV and IP was not as much. So what did it actually mean for us? Probably there were 2 points to be importantly noticing for us. One was that there was a 28% crossover to the IV regimen from the IP therapy arm. And the other was that with bevacizumab, probably the dose-dense chemotherapy weekly did not prolong the progression-free survival. So talking about the suboptimally cytoreduced, the first line therapy, the suboptimally cytoreduced also have to be dealt with in a specific way. And for that, we have these two important trials of the first line use of bevacizumab with taxane platinum, which is GOG 218 and then is ICON 7. GOG 218, stage 3 optimal and suboptimally cytoreduced patients and stage 4 patients as well. 3 arms, taxane platinum along with bevacizumab, and the other arm being bevacizumab with bevacizumab being continued as maintenance for 15 months. Very importantly, bevacizumab 15 milligrams per kg. The dose is very important. We'll come to the dose in ICON 7 as well. And we know that the primary endpoint of PFS was met. It was higher in Bev plus Bev maintenance compared to only the chemotherapy arm. The statistical significance also being there. ICON 7 also nearly reiterated the same thing, similar study design, similar number of more number of patients, but similar type of patients which were included. But very importantly, bevacizumab in the maintenance arm was given as 7.5 milligram per kg, which was nearly half the dose of GOG 218. And what was the result? The result was still similar. The PFS was improved. The overall survival also was improved. But very importantly, one has to understand, and it's a very important take home from GOG 218 and ICON 7 is this figure. This is the forest plot, which tells us that the most important improved overall survival was there in patients who had inoperable disease, who had a stage 4 disease, and who had a high risk disease. And high risk meant this thing. High risk meant that patients who were stage 3 and suboptimally debulked, or stage 4 patients, or for that matter, patients who could not undergo a debulking surgery. So the important message is that bevacizumab upfront may not be for everybody. Bevacizumab upfront has seen the light of the day only because the overall survival has improved, and in that high risk subgroup, which is stage 3 suboptimally debulked, stage 4 patients and no debulking surgery, very rarely we come across such patients, but then we should know what to do for them as well. Again, summary of GOG 218 and ICON 7, again a very important reiteration that it was only the high risk patients who had an improvement of overall survival, be it the stage 4 group patients in GOG 218 or the high risk group patients in ICON 7. That is how the FDA approval also has come for bevacizumab in 2018 in the first line. Now, after talking about what has really worked for us in the last 15 to 20 years, it is very important for us to know what has really not worked in the first line advanced ovarian cancer treatment patients. So like I said in the beginning, addition of topotecan or gemcitabine, or for that matter, any other third agent, interferons also have been used to taxane platinum, has not really worked and is not shown to improve the overall survival. Giving 8 cycles instead of 6 cycles, again, is a strict no-no. There is a good paper in Gynecological Oncology 2006 by Daizan et al., which tells us that this is not the way to go ahead. It doesn't improve the survival, it adds to the toxicity. If we talk about substituting cisplatin in place of carboplatin, we tend to do that in lung, we tend to do that in head and neck cancers very commonly, but should we do that in ovary also? Probably no. Boyce et al. In the Journal of National Cancer Institute 2003 very clearly mentioned, GOG 132 very clearly mentions paclicarb is bang on equal to paclitaxel and cisplatin. So if we have a patient who has a borderline performance status and we go ahead with carboplatin, one should not have any doubts in the mind. Paclicarb is absolutely the correct way to go ahead. Very importantly, when we are discussing adjuvant paclitaxel carboplatin, how can we not discuss GOG 3016, very important landmark study published in Lancet in 2013. And this is dose-dense paclitaxel and carboplatin versus conventional paclitaxel carboplatin. Dose-dense here meant that the carboplatin will be AUC 5 or 6, as the case may be, but the paclitaxel is going to be a weekly affair. And the paclitaxel was 60 milligrams per meter square every week. And then very importantly, what was the take home? The take home was that a huge OS benefit was seen, 40 months OS benefit was seen, which is huge. The other thing was that it was only for fit patients because there were higher treatment discontinuations with the dose-dense paclicarb compared to a conventional. There was no OS benefit in clear cell or mucinous variants. The maximum benefit, very importantly, was there in the suboptimally cytoreduced patients. And ICON 8, although similar design study, ICON 8, but it was mostly for patients who are European origin. JGOG 3016 was obviously patients who were more of Japanese origin and Asian origin. ICON 8 did not really replicate the difference between dose-dense and conventional, and they really showed that the dose-dense regimen was almost similar in terms of PFS. Probably a difference of ethnicity there, but certainly a food for thought. If the patient is fit enough, one can go for a dose-dense paclitaxel carboplatin as well. But then what if the patient is not fit enough? We have many of our patients coming in that manner into the OPDs. So we have Mito 7, which is weekly paclitaxel and carboplatin. We all know our weekly paclicarbs. For weak and infirm patients, this is well tolerated with almost equal results. And GOG 262 very clearly said that if we have such patients where we have a suboptimally cytoreduced patient and we are giving bevacizumab, dose-dense therapy should not be given because that doesn't add to the benefit. If you're already giving bevacizumab, dose-dense therapy is not the way to go ahead. Before I move into the PARP inhibitors, which is the buzzword nowadays in ovarian cancer properly, this is one study which I want to talk about when we're talking about the first line study and specifically when we're talking about what has not worked. So VILIA study, we are all aware, VILIA study is the first line study of the use of veliparib in the first line setting in ovarian cancer patients in stage 3 and 4. This is what we're talking about. So the randomization was 1:1:1 to control arm, which was only chemotherapy. The other was veliparib combination only, and the other was veliparib throughout. And veliparib combination meant that veliparib was being given with chemotherapy and no maintenance, veliparib along with chemotherapy, and there was a maintenance as well. What they really missed in this is that they did not give chemotherapy followed by veliparib. So there was no such arm so that it could really tell us as to whether the addition of veliparib to chemotherapy, like it was never been done in other trials, actually made an impact or not. This was a good study with a good result coming in, which was that the whole cohort also improved with the addition of veliparib. The HRD cohort, the BRCA mutant and the HR proficient, they all improved. The HR proficient had a very minuscule benefit and the HR was not significant. But the important information is here that if we talk about the HR proficient, the p-value is not significant. So very importantly, one has to remember that this is not a trial which is a very liked trial. The reason is that there were few crossovers, about 25 to 30% crossovers were seen, and there has not been a arm in this where the patient has been given chemotherapy followed by veliparib and veli plus chemo followed by veliparib maintenance. If that was the case, we would have come to know whether the addition of PARP inhibitors to chemotherapy actually does make a difference or not. And of course, veliparib is not available in India. Talking about availability, talking about PARP inhibitors, talking about maintenance therapies, we have to talk about the inhibitors, the PARP inhibitors which are available with us. So when we talk about maintenance, the maintenance started with bevacizumab. I've just spoken about GOG 218 and ICON 7, and I've also spoken as to how maintenance has been important and it has led to the improvement of PFS, and in the high-risk population, in fact, the improvement of overall survival as well. And it has only been seen when the bevacizumab has been given as maintenance and not only with chemotherapy. We all know that. And very importantly, the bevacizumab maintenance does not depend on the HRD or the HRR pathways at all. If there is no mutation, even then there is bev maintenance improvement. And if there is a mutation, even then the extended bevacizumab maintenance actually improves the progression-free survival. So this is free of BRCA mutation if we talk about the bevacizumab maintenance. But then, like I said, the buzzword is PARP inhibitors, and olaparib and rucaparib are certainly available. And if we talk about olaparib in the first line maintenance, we have the two trials. My previous speaker, Dr. Gupta, has very clearly and very lucidly talked about these two studies, so I'm not going into the details of it. SOLO-1 and PAOLA-1 studies. SOLO-1 study only in BRCA mutation, maintenance olaparib for 2 years, and PAOLA-1 study is patients, all comers. These patients had a tumor BRCA mutation, a non-tumor BRCA mutation, HRD positive, HRD negative. 50% of the patients had either an HRD positive or a BRCA mutation. Very importantly, olaparib maintenance again for 2 years, bevacizumab only for 15 cycles. And what were the results? The results were certainly favorable. So if we talk about the SOLO-1, the BRCA mutation population alone was taken, and the hazard ratio of 0.33 with a humongous PFS, 56 months versus 13 months. So probably a jaw-dropping PFS is what has been seen in SOLO-1. That is why it is lapped up by all the clinicians. If you have a BRCA mutation patient, you should give olaparib maintenance for sure. Talking about PAOLA-1, there are few points which have to be taken with a pinch of salt, especially is if the patient has got a BRCA wild type and it is HR proficient state as well. There it has not worked at all. There is no approval also. So the approval is also in for PAOLA-1, that is bev plus olaparib maintenance is only for patients who either have a BRCA mutation or they have a BRCA wild type status, but the HRD is deficient. The HR is deficient. Again, with the MyRights My Choice, we may not be doing that in our practice, but we have to know that in the trial, it was MyRights My Choice, which was used for HR deficiency status. So SOLO-1 and PAOLA-1, they are important. This current slide also tells us about what are the first line other PARP maintenance trials in ovarian cancer, and drawing the focus to my audience to two studies. One is the PRIMA study and the other is the Athena Mono study. PRIMA study is niraparib for the duration of 3 years, and Athena Mono is rucaparib for 2 years. And very importantly, niraparib maintenance and rucaparib in the first line has made an impact in all comers, be it the HR proficient, HR deficient, BRCA mutation, BRCA negative. But again, important to know that Athena Mono, although it has made a dent in all-comer or the intention to treat population, still there the FDA approval is still pending. June 2022, FDA has come up that we would like to have more on Athena Mono, and probably with the coming in of the overall survival, we'll be more confident to tell that Athena Mono should be used for all comers. As of now, for all comers, the only drug which is approved as PARP inhibitors maintenance is niraparib, which unfortunately is not available in India as of now. Now, talking from the first line to recurrent ovarian cancers, we do know about recurrent ovarian cancers. We've talked about the length and breadth of GOG 213 and OCEANS in the platinum sensitive population, in Aurelia in the platinum resistant population. We have the improved PFS with the addition of bevacizumab. We have nearly same overall survival with the addition of bevacizumab. Talking about from bev maintenance in recurrent setting to the PARP inhibitors also being there in the recurrent setting. In fact, PARP inhibitors came in the recurrent setting and then they eventually were extrapolated in the first line maintenance as well. And we talk about the recurrent setting, again, the 3 PARP inhibitors, olaparib, niraparib, and rucaparib in that order. So for olaparib, we have the study 19 and the solo 2 trial. For the niraparib, we have the NOVA study. And for the rucaparib, we have the Ariel 03 study. So Ariel 03 study told us that if the patient had a somatic or a germline BRCA mutation status and at least 2 lines of therapy, addition of rucaparib improved the PFS. Same was the case with niraparib in the NOVA study. The solo 2 study patients only had BRCA mutation in solo 2, and study 19 they were catering to the platinum sensitive recurrent ovarian cancer patients. Now, talking about the tissue agnostic approval, we all know that in May 2017, pembrolizumab has been approved as in an accelerated approval manner by US FDA for MSI high status or MMR deficient status for any histology, and ovarian cancer also is one of them. So all this is something that we are all aware of. Now, talking about something which has come in only the last 1 year or so, the important the conferences which have happened in 2021 and 2022, what are the new things which have come up, and how are we going to really take these things forward when we are going to move to the next year now. So the phase 2 Ovario study is a phase 2 study of niraparib plus bevacizumab in advanced ovarian cancer following the frontline platinum based chemotherapy along with bevacizumab. So this is the schema. Niraparib has got a weight based dosing schedule. We all are aware of that. So these patients who are having at least a stable disease after platinum based therapy and after surgery, they were given niraparib plus bevacizumab. It is a single arm study with a primary endpoint being PFS at 18 months. And if you see divided between the homologous recombination deficiency, HR proficiency, or HR not determined, patients who are having an HR deficiency did the best for niraparib plus bevacizumab. So it is almost like the Paula study. Paula is phase 3. This is phase 2 study. But niraparib also can be combined with bevacizumab, and it is found to be safe. Talking about the PRIME study. PRIME study is a phase 3 study of the use of niraparib as maintenance therapy in a newly diagnosed advanced ovarian cancer in the first line. How it is different from the already known PRIMA study is that PRIMA study used patients where there were stage 3 patients who had to be suboptimally cytoreduced.
Dr. Rajat, please try to finish in 1 or 2 minutes, please.
Yeah, sure. So PRIMA study had patients where there was stage 3 patients who were suboptimally cytoreduced, but here the patients in PRIME study, they were stage 3 patients who were optimally cytoreduced, and it was seen that the forest plot very clearly says that patients who are having an HR deficiency or a proficiency or a BRCA mutation positive or a non-mutation status, all of them benefited with the use of niraparib. That is why if you have to choose one PARP inhibitor for the all-comer population in the advanced setting post platinum based therapy, it has to be niraparib. Athena Mono, again, Athena Mono is a study design which is almost similar to the PRIME study. Frontline patients of stage 3 and 4 post-surgery and adjuvant therapy being randomized to receive either placebo or rucaparib is exactly what Athena Mono is all about. Rucaparib in the standard dose of 600 twice a day. And it was seen that rucaparib increased the PFS almost 2.5 to 3 times CFS as compared to the control arm in the HRD population. So, and also it was seen to improve in the all comers. But like I said, that there has been an application which has been submitted to FDA as of now, but then this application is still pending. There is no approval of using rucaparib in all comers. The approval is only for patients who are HRD or the BRCA mutation status. These are the indications where maximal benefit was seen. Very important is this slide. There have been certain withdrawals of late line indications of PARP inhibitors, post 3 lines, post 2 lines in BRCA mutated patients. We're talking about olaparib, we're talking about rucaparib. All these indications have been withdrawn recently. The reason has been that there has been found to be a potential detrimental effect on overall survival of use of PARP inhibitors in this particular setting, be it niraparib, olaparib, or rucaparib. The last 2 minutes, I'm going to talk about the ESMO 2022, where there is this trial, which is the opinion study, which has come, which is maintenance olaparib monotherapy in platinum-sensitive relapsed ovarian cancer, where there has been no germline BRCA mutation. So we do know that the PARP inhibitors can be used in the PSROC category, and PSROC category, it has been used. It is a single arm study where it has been seen that the use of olaparib has improved the PFS in patients, especially again HRD positive and the BRCA mutation status positive. Talking about the Mediola study, Mediola study is also a landmark study. Again, in ESMO 2022, it has been published presented by Banerjee et al. Mediola study told us that if we have patients who are PARP inhibitors naive and they are VEGF inhibitors naive and they have had progression on first line therapy and they are not BRCA mutant, what do we really go about doing? So they had 2 cohorts. They had one cohort which is olaparib plus durvalumab, and the second cohort was olaparib plus durvalumab plus bevacizumab. So olaparib plus durvalumab had a little benefit, but it was not as good as the benefit which was seen with the triplet combination. In fact, the pre-specified endpoint was not achieved in the doublet, but it was achieved in the triplet. So the important message is that if you have a patient who is at least 1 line of relapse ovarian cancer, not having received PARP inhibitors and VEGF inhibitor, a triplet of ola plus durva plus bevacizumab improves the progression-free survival, and it should be given. And we're talking about patients where there is no BRCA mutation positive status. So we've talked about the Mediola study as well. So to conclude, I would say that cytotoxic chemotherapy still has a role. There is an evolution which has happened. Taxane platinum still remains there. Role of IP therapy becomes clearer once we have a fit patient. Angiogenesis is an established target. Bevacizumab is FDA approved, be it in the recurrent setting or be it in the first line setting. We have to choose our patients wisely. PARP inhibitors are here to stay. They are going to evolve more and more. We had Ola, we have now Ruca. From times to come, we are going to have Nira as well. Niraparib is the one which is approved for all comers. The labels are expanding. The understanding is improving. Now we have the reversion mutations for PARP inhibitors also coming up. We have not included that in the presentation because of the time limiting factor. The role of immunotherapy is promising. It has not been studied too much, but maybe if you have a patient who's a MSI high status, immunotherapy can be given as a tissue agnostic marker. So with this, I conclude my talk. I thank the audience for the patient listening, and back to the organizers. Thank you.
Thank you, Dr. Rajat. You have done extensive efforts for making this first line very clear for all of us in the ovarian cancer. So we are now, I think, good updated in the ovarian cancer. Now I invite Dr. Lalit Sharma. He is a consultant medical oncologist in Manipal Hospital, Jaipur. He will be talking on a latest update in head and neck cancer. That will be the role of nimotuzumab as a concurrent chemoradiation in a nasopharyngeal cancer. So Dr. Lalit Sharma, over to you.
Thank you, Dr. Tarachan, for the invitation. Thank you, organizers, especially Biocon, for the opportunity. I hope my screen is visible and slides are visible. Am I audible?
Yes, sir, your voice is audible.
Am I audible?
Yes, sir. Can you please share the screen?
Yeah, sure. I hope the slides are visible.
Yes, sir. It's visible.
So, the topic allotted to me for the evening is to discuss the role of nimotuzumab in the advanced nasopharyngeal carcinomas in the definitive setting, that is, along with chemoradiation. Now, basically, head and neck carcinomas make a huge bulk of malignancies in our setting, wherein tobacco is so prevalent. So, head and neck being the most common diagnosed malignancy all over India, especially in Rajasthan. So the outcomes have gradually improved with early detection, introduction of concurrent chemoradiotherapy in cancers which are not amenable to surgeries. So is the case with nasopharyngeal carcinoma, wherein concurrent chemoradiotherapy is very well established as a agent to treat locally advanced nasopharyngeal carcinomas. But in our quest to improve the outcomes, we are gradually looking into the possibilities of looking into the role of biological agents in improving the outcomes in these patients. So we had a phase 2 trial which showed that nimotuzumab, when added to radiotherapy, it improved the clinical efficacy. It was not unknown. It was not known whether nimotuzumab would provide survival benefit also. So probably this provided the background to the investigators. This was the thought process wherein the investigators designed this particular phase 3 trial. It was conducted mainly in China. The key eligibility criteria was patients who had locally advanced nasopharyngeal carcinomas, wherein the patients had a good performance status and the primary tumor was measurable radiology. Patients were randomized into a 3:1 ratio in experimental arm having nimotuzumab along with concurrent chemotherapy and radiotherapy. Concurrent chemotherapy was used in the form of cisplatin in a 3-weekly fashion in a dose of 100 milligram per meter square, along with radiotherapy, which was conducted in the form of either IMRT or CRT. In the observer arm, nimotuzumab was replaced with placebo along with concurrent chemotherapy with cisplatin and radiotherapy with IMRT or CRT. The primary endpoint of this particular study was a 5-year overall survival rate. The secondary endpoints were overall response rate, disease control rate, disease-free survival, locoregional recurrence free survival, and the distant metastasis rate, along with the safety profile of the drug. We would consider this study to be well powered with a decent number of patients. The patients were divided or randomized into a 3:1 ratio versus experimental in the observational arm. Around 53 patients in each arm discontinued the therapy, so which meant that a larger proportion of the patients in the placebo arm dropped out of the study or actually discontinued due to the adverse events. As far as both as far as the demographics of the both arms are concerned, both the arms were pretty well matched, be it for age, gender, performance score, stage, or whether the net dose of radiotherapy or chemotherapy which were delivered to the patients is considered. So at the end of the study, on analysis of the data, the 5-year overall survival rate was significantly better in the experimental arm, that is the nimotuzumab arm, which showed a 5-year overall survival rate of 76.9% versus 64.3% in the observer arm. This was statistically significant with an impressive hazard ratio of 0.64, which meant that addition of nimotuzumab to concurrent chemoradiotherapy provided a 12.6% absolute survival benefit at 5 years. Even on the subgroup analysis, this benefit was seen across all arms, all subgroups. Though patients who did not receive a decent amount of chemotherapy, that is less than 2 cycles of concurrent chemotherapy, were not able to avail the benefit of biological agent also. And somehow patients who were not able to receive a decent number of sittings of radiotherapy, that is less than 25 sittings of radiotherapy, derived more benefit out of the biological agent. So as far as the disease-free survival goes, even with the disease-free survival, there was a trend towards favoring towards nimetuzumab, but it was non-significant statistically, with a DFS of 50.6 months with nimetuzumab arm versus 42.6 months with the observation arm. As far as response rates were considered, patients with nimetuzumab had a overall complete response rate of 57% versus 45%, though the overall response rate and the disease control rate was almost similar in the arms. Similarly, the loco-regional recurrence-free survival was also better with nimetuzumab with a p-value of 0.05. Though it was statistically not significant, similar was with a distinct metastasis-free survival, which was also not statistically significant. It also depended on the type of the therapy which the patients received. The proportion of the patients receiving IMRT versus those receiving the conformal radiotherapy was similar in both the arms. It was around 2/3 of the patients received at IMRT in both the arms, and the 1/3 who received CRT in both the arms. IMRT in both the modalities of radiotherapy, the advantage with biologicals was pretty visible with patients who received IMRT. The median survival was 71.7 months versus 43.2 months in the observer arm. With the conformal RT, 49.4 months versus 18.6 months. Now, very interestingly, the advantage was rather more steep. The magnitude of advantage was rather more with conformal RT rather than IMRT. And this probably could be attributed to slightly technically less superior modality being benefited with advantage of the biological agent. Similarly, if you see that the complete response rate was even better in the conformal RT arm, though overall the complete response rates were better with IMRT, but the magnitude of the difference between the experimental and the observation arm, that is nimetuzumab versus placebo, was seen more with the conformal RT. So probably this gives us an idea that in case for some reason we are using conformal RT, addition of nimetuzumab probably would provide a even more greater magnitude of advantage in adding nimetuzumab. The adverse effect profile when it was studied, there were no new safety concerns with the addition of nimetuzumab. In fact, if the study data be believed, the nimetuzumab arm in fact had lesser toxicity, even of higher grade, and discontinuation was also somewhat less as compared to the placebo arm. Common adverse events which were seen were cytopenias, neutropenia, lymphopenia, thrombocytopenia. Other than that, transaminitis was seen in both the arms, somehow seen more with the placebo arm instead of the nimetuzumab arm. Another interesting fact, very difficult to somehow believe, is that the radiation-induced oral mucositis rates were also very less. It's usually not seen in endemic carcinomas. Only single-digit percent of patients suffering from oral mucositis in this particular study. So to conclude, nimotuzumab combined with chemoradiotherapy in the treatment of locally advanced nasopharyngeal carcinoma had better efficacy. The 5-year overall survival rate was increased by 12.6% with a 36% risk reduction. The complete response rate was also increased by 13.3%. And nimotuzumab plus chemoradiotherapy had a really good safety profile also. Thank you for the patient hearing.
So,
hand over the proceedings to you.
So Lalit, are you ready to start nimotuzumab in nasopharyngeal cancer?
Well, I would say I'm tempted with the data, but I would like to, I would wish that this data matures before I kind of bring it into my day-to-day practice.
Thank you. It's at least the latest addition, and we have seen the addition in the nasopharyngeal cancer after a long time, and we think that it may change into the clinical practice, and we will be able to give the benefit to patients also. So, so today this was the final talk, and now I thank to all the speakers and the faculties, and including the moderator and the panelists for making today's session more realistic and more wonderful with the essence of knowledge. And at the same time, I thanks to our pharma partners, Merck, AstraZeneca, Novartis, Pfizer, Mylan, Lupin Oncology, Fresenius Kabi, Sun Oncology, Roche, Zydus, Entas, Mankind, Cipla, Ariad, and Dr. Reddy's. And same time, I also thanks to the Horizon or Healthy Blossom for making this conference a smooth picture. So good night, everyone. Thank you all.